People to People India, or HPPI, is hosting the in-person session in New Delhi, India. I would invite Jahangir Alam, who is right now in the meeting hall of HPPI in Delhi, to say a few words. Over to you, Jahangir.
Thank you, Shobha. Can you hear me?
Yes, very clearly.
Okay. So good morning, good afternoon, and good evening to everyone joining from different parts of the world. A very warm welcome to all of you. We are gathered here in New Delhi, India, at the Humana People to People India meeting hall, where we are delighted to join today's AIDS 2026 affiliated independent event. It's a great pleasure to host this event in person and to connect with colleagues and partners. We are excited to hear from our distinguished speakers who are joining us from more than 25 countries around the world. On behalf of Humana People to People India, I would like to extend our sincere appreciation to the CNS team for organizing this wonderful event and for providing this platform for knowledge sharing and collaboration. Thank you all for joining us today. With that, I would like to hand it back to Sovaji. Thanks.
Thank you, Jahangir. This session is also live streamed on YouTube, where if you use the closed caption or auto translate option, you can follow the discussion in any language of your choice. Today's event is jointly organized by National Coalition of People Living with HIV in India, or NCPI+, HPPI, Global Network of People Living with HIV, GNP+, Y+ Global, AVAC, International Community of Women Living with HIV, ICW Asia Pacific, YPeer Asia Pacific, APCOM, M+ Foundation Thailand, Youth Lead Voices, Asia Pacific Cities Alliance for Health and Development, APCAT, Positive Women Together in Action, Eswatini, National Empowerment Network of People Living with HIV in Kenya, Nepal, Rekat Peduli, Indonesia, Khana, Cambodia, Health TV Online, Nepal, She and Rights, TB People Eswatini, TB People Botswana, TB People Zimbabwe, People's Health Organization, PHO, Gujarat AIDS Prevention, GAP, ISRCDE, Asia Pacific Media Alliance for Health, Gender and Development Justice, APCAT Media, Global AMR Media Alliance, GAMA, Development Justice for Older Persons, DJ for OP, Prevent, Find, Treat All TB Campaign, Global Center for Health Diplomacy and Inclusion, SEHDI, and CNS in collaboration with UNAIDS. As we know, the political declaration on HIV/AIDS, which was adopted recently by 149 countries at the UN high-level meeting, commits to end AIDS by 2030. This declaration comes at a time when the rollback of rights for key populations, women and girls, and marginalized communities is worsening globally. While recognizing the crucial role of communities and key populations, the declaration also identifies gaps in the HIV response, including reductions in global financing for HIV and the impact of recent disruptions on HIV services. However, it falls short on realizing the sexual and reproductive health and rights of women, adolescents, and girls and key populations, including LGBTQI+ communities, sex workers, and those living with HIV, whose rights are under threat of being rolled back in many countries. Punitive laws for gender diverse peoples are expanding and threatening communities that are already at a much higher risk of acquiring HIV. The latest in the series of anti-rights pushbacks is the regressive draft African Charter on Family, Sovereignty and Values that undermines gender equality. Governments must reject such regressive charters and other pushbacks and instead advance gender equality and human right to health, which are fundamental and indivisible human rights. The HIV community leadership has proven that empowerment is not given, but is taken by fierce community-led struggles spanning years. We owe the gains made in HIV response to the community-led movements worldwide. We need to ensure that the people most affected remain central drivers to shaping health responses, and that trained community people lead community-led health service delivery models if we are to end AIDS and TB. We call to formalize community rights, roles, and responsibilities and fully fund HIV and TB responses, including the community-led responses. For today's session, friends, we have over 45 speakers from over 25 countries, and all of them are equal. So please adhere to your time schedule of 5 minutes each. Without any further ado, we begin today's event with keynote lightning addresses to provoke us to rethink, rebuild, rise, and put people first to end AIDS and end TB. I welcome our first speaker, Eamonn Murphy, UNAIDS Regional Director for Asia Pacific, Central Asia, and Eastern Europe. Over to you, Eamonn.
Thank you very much, dear Shobha. Distinguished colleagues, speakers, friends, above all, the community leaders from across the world that joined us today. It's a privilege to be with you here at the beginning of what's going to be a very important discussion in the lead up to AIDS 2026. I'd like to start by thanking CNS for bringing together communities, experts, partners of all types across regions, looking from different perspectives at some of the real challenges for us as we move forward for the next 5 years. So congratulations to everyone who helped secure the new political declaration on HIV/AIDS adopted just 2 weeks ago at the UN high-level meeting in June. It's a difficult political context that we're all working within, and it was an important joint, and I stress that, it was a joint win. It was critical to have voices of communities, of other technical partners working with governments ahead of the actual meeting, but preparing the text and agreeing and getting colleagues who are new to the area of HIV to understand why these commitments are critical and why some of them are repeating commitments that were already there. We all know it's a time of not just funding cuts, but it's pressure on civic space, which is shrinking in many places. There are attacks on human rights. There's pressure on multilateralism. The declaration is important for a whole range of aspects. But most critically, it's because communities must be central to service delivery, to the accountability, the implementation, and critically, the governance. And we just finished our program coordinating board, which is the joint board for UNAIDS, and communities are part of that governance structure. And it was very clear in light of transformation that we're going to continue going through over the next years, that critical role of community in global governance is unique to the UNAIDS board and needs to be preserved. The recognition has been earned through decades of activism, of sacrifice, of leadership, of courage, and practical work as well. It's all mixes, sitting down and helping people write global fund proposals, advocating to politicians, working in all different dimensions, getting people in the community to understand. So I don't need to tell you, this audience, what communities do. You do it all in different ways at different times. And sometimes we repeat again what we've done before. So let's just briefly focus on the new political declaration and what it requires from all of us. First, none of the global targets can be achieved without communities. That's critical and was repeated time and time again during the last 3 days of our program coordinating board. I was reaffirmed during our program coordinating board about the collective understanding. There's always different voices, but the collective understanding that AIDS is not over, there's more work to do, but central to the success is the role of communities, the participation of communities. The 95, 95, 95 targets depend on trust, testing, rapid linkage to treatment, retention in care, viral load literacy, and making U equals U a lived reality. The 10-10-10 targets are also community targets, reducing stigma, inequality, violence, and removing punitive laws requiring communities to document what is happening, demand accountability, and defend rights. The 30-80-60 targets make this explicit. By 2030, community-led organisations should deliver 30% of testing and treatment support, 80% of prevention for key populations, and 60% of programs addressing societal barriers. These are not side commitments in the political declaration, nor are they new. They're 5 years old for some, and they build on previous ones for others in the case of the 95 targets. But like the 310s are not new. So we can use these to hold governments accountable. What have you achieved in the last 5 years? Do a stock take. What will you do in the next 5 years? It's going to be a critical period for the response to HIV. These commitments recognise a proven fact that communities make the HIV response work and are critical to success. So let's use these targets as an advocacy tool to claim the resources, protection, and decision-making power communities need to hold governments and partners accountable. It's not just governments, it's all partners. Are you actually participating in the decision-making, or are you there? It's a big difference. And so that's critical to the process. And this political declaration, in addition to the global AIDS strategy, gives it power. I was also reaffirmed that many member states were talking about the two, the political declaration and the global AIDS strategy. And sometimes they want to draw on the global AIDS strategy because it goes further than the political declaration in detail. But the second area, community leadership, must be financed, not simply applauded in meetings. A transition to domestic financing that leaves community-led services unfunded is not sustainable. So when we talk sustainability, funded community-led services are critical. Cambodia's recent achievement of the 95-95 targets is fantastic. Thailand's integration of community-led HIV services into national HIV response show in two different examples what is possible when national leadership, community partnership, and people-centered services come together. Forgive me, I look after 2 regions in the world, so there are plenty of other regions and examples at country level across the globe. Yet too often, treatment and diagnostics are protected through state budgets, while prevention, the rights-based programs, and the community outreach, the social protection areas as well, depending on external funding or not accessible. A service without a budget line is a service at risk in these days. We must work together to get these critical areas, especially as we see global fund transitions happening in countries and reduced international support and financing. This is critical for us to get these in funded lines by national budgets. UNAIDS will continue to advocate for community-led responses to be funded through social contracting, domestic financing, national budgets, costed community service packages, and for communities to shape priorities, policies, and budgets from the start into the implementation to the evaluation. Third area, innovation and integration must make services more accessible, not make trusted community services disappear. Self-testing, long-acting prevention, differentiated treatment, viral load monitoring, and U=U can transform lives, but only with that trust, the peer support, the demand creation, and the community-led monitoring behind them. So let us judge the innovation not by how new it is or how small scale it is, but by who can actually access and benefit from it. Integration into services should mean better person-centered care, with both the HIV and TB services working together. We're not seeing that enough in enough places. We will not end AIDS while preventable TB deaths continue. We've got to bring these together. When we talk about integration, it's not silos within the health system, it's bringing the linkages and improving the quality of services for the people who need it. Finally, domestic leadership and global solidarity must reinforce each other. The communities must increase domestic investment, must increase this, including for in-community-led services and responses. But international partners also cannot step back, just as communities are being asked to do more with less. HIV prevention, rights-based programs, and community-led services cannot be the first to be cut. We in the United Nations, and my colleague Pauline Chan is online and others are here, we will work together. UNAIDS is the joint program, not just the secretariat. We will work together to continue to support countries to protect domestic financing while advocating for that sustained international funding for communities' work to continue. This is why this event and others like this in the lead up and at the IAS are going to be critical. It brings together community and key population-led organizations and partners to focus on what must be scaled, which barriers must be removed, who must be accountable, who's achieved successes, how do we learn from each other? So as we approach AIDS 2026, this is a moment to turn the political declaration into action, demand its implementation with effect. We have the declaration, we have the science, we have the leadership of communities, we have a partnership of support from the United Nations, from technical partners, from other parts of the community structures in our countries, the human rights groups, the youth groups, all different parties coming together for this. What we need now is political will to match the ambition with resources, protecting rights and turning the commitments into change in people's lives. Thank you, Shobha. I hand back.
Thank you very much, Eamonn, for your powerful and encouraging words. I am now honored to welcome Dr. Nittaya Phanuphak, Executive Director, Institute of HIV Research and Innovation, Thailand.
Thank you very much for the opportunity to speak to you about Thailand's experience on community-led health services. My name is Nittaya Phanuphak, and I'm the Executive Director of the Institute of HIV Research and Innovation, or IHRI, which is based in Bangkok, Thailand. I'd like to start by pointing out the intersecting identities of people that we usually serve as healthcare providers. And these are intersecting identities which are commonly devalued by mainstream society, causing pervasive stigma and discrimination. And in Thailand, since 2015, we have established community-led health services as a way to address low uptake of health services among these populations. And under community-led health services, services are designed and co-delivered by lay providers who are members of the communities who are trained and qualified to ensure that services are needs-based, demand-driven, and client-centered. We use these three principles in designing community-led health services. The first one is demedicalization, which is when you identify certain clinical roles which can be task-shifted or task-shared from healthcare professionals to lay providers or to the clients themselves in order to ensure that services are not kept in the hospitals or clinic but are brought to people in the community. And the next principle is simplification, which is when you find less complex way to deliver services while retaining efficacy and quality of care. And then the last one is differentiation, which is when you tailored services accordingly to the needs of the clients in order to maximize the use of your limited resources and manpower. And one great success example of community-led health services is the key population-led same-day PrEP. Here, lay providers are the one who provide HIV testing as well as give out PrEP as prescribed by doctors to their clients within almost an hour of a client coming in for HIV testing. And key population-led PrEP service has served almost 60% of the overall PrEP users in Thailand, and it demonstrated strongest epidemiological impact and has been the most cost-effective PrEP service delivery model in PrEP scale-up in our country. And with these evidences, we have been successful in pushing Thailand MOPH to announce this regulation to endorse or legalize the roles of lay providers in not only providing counseling, but also to collect blood samples or STI samples and perform rapid diagnostic tests in order to interpret test results and report test results to their clients, and then give out drugs for treatment or for prevention as prescribed by the doctor. The co-design and co-delivery approach has also been applied for trans health, and this is led by the Tangerine Clinic, where the sexual health service, mental health service, gender affirming care, and social legal service are integrated into one location and served by one multidisciplinary team. And over the past 10 years, Tangerine Clinic has served almost 9,000 transgender clients with very high uptake of HIV and STI testing, as well as high successful linkages to treatment and prevention. The co-design and co-delivery approach has also been applied in harm reduction services. And here, substance use harm reduction, mental health, sexual health, and social legal services are integrated into one place. And these services are usually not co-located, not coordinated, or may not be even existing. And here, the team of multidisciplinary lay providers, as well as psychiatrists, psychologists, and legal experts are working together. And we have seen that these comprehensive community-led harm reduction services are successful in leading to reduce substance use among clients, as well as we have seen positive impacts on family relationships, financial status, as well as the increasing use of PrEP and condom among the clients. So to conclude, community-led health services have successfully addressed service access for health conditions which are highly stigmatized, and demedicalization, simplification, and differentiation are key principles in designing these community-led health services. And together with the people-centered approach, we will be able to design many more integrated and innovative service delivery models that meet people where they are. And thank you very much for listening, and I hope you enjoy the rest of the meeting.
Thank you very much, Nittaya. Our next speaker is Dr. Lucica Ditiu, Executive Director, Stop TB Partnership. Welcome, Lucica.
Thank you. Thank you. I think your biggest problem today, Shobha, will be to make people keep the time, because I think
yes.
Eamonn has a different watch than mine, but maybe I will use his watch and speak for 17 minutes. No, I'm kidding, but
okay.
As I see, we were supposed to speak 15 minutes, so we are already at almost 11. I will not use all my time because a lot was said by Eamonn and the colleague before. I just want to say three things. I think, as you know, Stop TB Partnership on the TB space, we started engaging civil society and communities with big difficulties. Because of the lack of funding, we never benefited as an overall community of TB, not Stop TB, of the funding that PEPFAR Global Fund provided for HIV for strengthening the communities. And that's why we constructed a very good community networks and survivors with much less. Happily, I think we are in the same kind of space where we should try and be with networks of survivor and civil society communities engaged in a meaningful way in the TB response in every single country. We were not there. And I think there is no doubt, and I think the point today from this conversation should not be actually about our communities delivering meaningful support and so on. That's established, that should be a no-brainer, and that should be never questioned. I think we should have zero doubts that if we want to add TB, HIV, malaria, but actually hepatitis, sexual transmitted diseases and so on, without having the communities and the grassroots organizations involved, not just in advocacy, but in delivering services, in accompanying people to get diagnosed, in demystifying the myths, in supporting people that go through a lot of isolation, stigma, and fears, in making sure that actually access to these services is for everybody available. That is clear, and that should be in the minds of everyone, and that we should make sure that goes up to the government. So my first point is, it's absolutely a no-brainer, and it's absolutely very clear that there is no, should be no hesitation and no question on the role that the communities and civil society play, the essential, in ending these diseases. The second point that I want to say is there is a however, and that however is that the time in which diseases were, especially these three ones, and especially TB and HIV, if you want, because we speak about that a lot these days, were fought separately, is over. The exceptionalism, I have to say, because there was was surrounding a lot of the HIV work, is over. So unless we are smartly, I'm not even sure if integrating, but putting the communities together to serve the people that are very often the same one suffering from the two diseases, to really push together. And we continue to have different, we will continue for a while because it's constructed like that. But the different streams of funding, the different conversation, things will not fly. So this very separate approaches in which we were going on one direction and the others on the other direction, it will not lead us anywhere. And we will have to do this work together much more than before. Because I have to say that indeed, for how many years? I think Shobha, Eamonn, we know each other for so long time, and we speak about integration of TB HIV services. We were all much younger, sexier, slimmer, 15 years along the way, that is not really integrated very well at national level. And it's maybe because people understand it in different ways. The country's systems are in different places, and therefore they cannot allow that, and so on. So it's a moment of very serious reflection, because the time of all these different streams of funding going left and right, it's over. The third point that I want, and this is my last to say, is this. We should all invest in interventions of communities and civil societies that can resist and that can be sustained. I'm sorry to say, but all these billions of dollars that went in strengthening communities and health systems and so on, not much in communities, let's be right. All this in fighting these diseases, let me put it this way, constructed a lot and saved a lot of lives, which is, and will be absolutely core. But it constructed very few things to remain. The interventions, the projects, and the work that is done with external funding that is at risk of being closed and disappearing the moment the funding stops, that's something we should not do. And every single organization is essential in thinking, is what I'm doing today going to be somehow maintained if this donor or this money ends? If the answer is no, it can be just a momentary thing that can save a group of people, which is fine to go ahead, obviously. But if there is always a risk that will stay on your back, that the moment these funds are over, the entire architecture created for an organization or delivery will end, this will be a big problem. So we have to think of investing in things that are resilient and sustainable. And in that comes the fact that there is always, at least, in some of the regions, a bit of a friction between government and civil society and communities. Because obviously the government is very concerned, usually, about the big demand, about the access for everybody, about the rights of people, about the equity, and so on. Unless the governments understand the value, and that's a responsibility for all of us to work. And I say that a lot of the external funding is guilty by encouraging and funding the track for communities, which is absolutely essential, but without at least involving the government. So it created an additional point of friction, because the governments were very often saying, we don't know what these communities are doing. The moment the money are over, we are not intervening. And the communities also were not much involved in linking and understanding what the government wants, and criticize it, and ask for the rights, and ask for the access. So the time to have the same narrative that happened in the last 25 years is over. And unless we say the things as they are, we will not go anywhere, because the money will be in a very different approach. I leave this by saying we and Stop TB are absolutely strong believers in communities, civil societies, and survivors of everything, TB, and people living with HIV, and people affected by hepatitis and so on. It's a major force. I think we should come and sit together and see how it's addressed. We cannot just integrate everything everywhere, because you lose the beauty of the specificity of each of these communities and diseases. I gave in UNAIDS, in the UNHLM meeting, we did an event together with UNAIDS, Stop TB, and RBM, very beautiful. And I spoke about the fact that when you have, when you paint something and you have the colors on this thing where you take them, so you have a red, you have blue, you have green, and then if you integrate them all and merge, you get actually a very ugly color. You lose all the beauty of red and green. So that's why we should not just automatically say integrate everything as it is, but acting together for the sake of people that we want, and we want to serve all of us. It will be very important. Thank you very much.
Thank you very much, Lucica. Thank you. Let us now hear from Dr. Mitchell Warren, Executive Director, AVAC, and Governing Council member of International AIDS Society.
Hi there, my name is Mitchell Warren. I'm the Executive Director of AVAC, and I am so happy to be invited to share some remarks with all of you, and just so sorry not to be there in person or even live at this particular moment. But I'm so grateful to have the opportunity to share this message. As we all gather here in early July, just weeks before the International AIDS Conference taking place in Rio de Janeiro in just a few weeks' time, this is one of the most critical moments in the HIV/AIDS response. Now, of course, we've said that many times over the last 45 years. It was important many, many years ago when all we had were condoms and behavior change programs, when getting a diagnosis of HIV meant a death sentence because there was no antiretroviral treatment. And it was a critical moment then to advance the development of antiretroviral treatment. Fast forward to the late 1990s, when antiretroviral treatment was developed but wasn't available to the vast majority of people living with HIV. That was a critical moment in the field, and it brought us both the Global Fund to Fight AIDS, TB, and Malaria, as well as PEPFAR, the President's Emergency Response for AIDS Relief, in the early 2000s. And it's because of those critical moments that we now have nearly 30 million people living with HIV accessing antiretroviral treatment. And yet we still have gaps in that coverage. We still have people not diagnosed and not receiving the life-saving antiretroviral treatment, both for their own lives as well as to prevent onward transmission. And yet it's been a critical moment in HIV prevention for the past 12 years, with the development of safe and effective pre-exposure prophylaxis, or PrEP. So we could move beyond male and female condoms. In 2006, we began to offer voluntary medical male circumcision, which we know to be a safe and effective intervention. And then in 2012, the approval of the first PrEP agent, an oral PrEP pill taken every day. And it was a critical moment then that we make good on the science and deliver PrEP to all who could benefit from it. And yet we failed to meet that moment. Lo and behold, years passed. We have now a dapivirine vaginal ring and injectable cabotegravir that came into the market in the last 5 years. And it was a critical moment then to deliver them with speed, with scale, and with equity. And yet we didn't. So here we stand in July of 2026, where we have the latest intervention, injectable lenacapavir, an every 6-monthly injectable, that is a remarkable product. But so too is cabotegravir, so too is the dapivirine vaginal ring, so too is oral tenofovir emtricitabine. So why is this moment more critical than any of the past? Well, it's a cruel irony that the greatest scientific opportunities, including lenacapavir, have come to us just as we face the most challenging political and economic time in the HIV/AIDS response. And it started on January 20th in my country, the United States, and tragically, political leadership failed. Political leadership not only failed to meet the moment, but political leadership began to peel back the great advances that now inhibit our ability to translate great science into public health impact. And that is why this moment, more than possibly any other in 45 years of the HIV/AIDS response, is the moment that we have to rethink what we do, why we do it, how we do it. We need to rebuild. We are not rebuilding to January 20th. We are rebuilding an entirely new architecture that not only needs to deliver on HIV and AIDS, but needs to deliver on tuberculosis, malaria, non-communicable diseases, a range of sexually transmitted infections other than HIV. And we need to rise to meet this moment in a way that we have not as a collective, as civil society advocates, as researchers, as political leaders, as funders. This is our moment because we have the opportunity to do what we haven't been able to do in 45 years, to help get everyone living with HIV access to antiretroviral treatment, to help get prevention in all its forms, condoms and circumcision and PrEP, to all who can benefit from it. That we need to rebuild the scientific enterprise to make sure that we still develop a vaccine and a cure, because we can. Because we can and we must. So as people think today at this important meeting, as well as think ahead to the Rio conference in just a couple of weeks, this is our moment to come together, to rethink, to rebuild, to rise, to put communities at the center, and to do what the science allows us to do, if we choose to act on it. I hope you'll join me. I hope you'll join colleagues around the world, everywhere, in rethinking, rebuilding, and rising. Thank you so much and have a great meeting.
Thank you, Michelle. Thank you very much. And last but definitely not the least, we have with us Dr. Urvashi Singh, former head of Indian government's National TB Elimination Programme and Professor of Microbiology at All India Institute of Medical Sciences, New Delhi. Dr. Singh, we are really grateful to you for joining us at this very unearthly hour for you from the part of the world you are joining us. Over to you.
Very good afternoon, Shobha ji. Kindly pardon my video not functioning.
All right, no
It's
problem.
an honor to be with you and with the audience and with the esteemed speakers that have just concluded very salient points just before me. I actually second each and every point made by Dr. Eamonn, Dr. Lucica before me. So I will go ahead with a few points that I thought I must share with the august audience here. I'm taking the discussion back to science and how that shapes how we take care of our patients. So if I may, the idea of bringing subclinical tuberculosis to the fore had been on my mind for more than 15 years. We published some work on subclinical tuberculosis as early as 2016, meaning that we started the work in 2011 and 12. And what we actually found was not all TB was clinically overt, in the sense the patients may not come forward with their symptoms because it is very early stage of the disease and it is asymptomatic at that early stage. So I was able to actually push this concept as an implementation during my tenure as the Deputy Director General of NTEP in India. What we did was we moved away from, actually waiting for patients to become symptomatic and coming into the system, we went back a step and we wanted to bring in patients for care before they actually turned symptomatic, meaning we started looking for asymptomatic TB, especially in the high-risk populations, which in India is practically close to 50% contributed by low BMI patients who have the BMI less than 18.5. We have a large contribution from those who have diabetes, those who have HIV, and a few other risk conditions like smoking, alcoholism, past TB, contacts of TB, and so on. So this change in our strategy to look for asymptomatic TB using X-rays as the screening tool, which is recommended, which is the only screening tool recommended, actually expanded our reach to bring in more and more patients into care. So much so that if I may actually quote the examples of countries who've done population level screening to bring a change in the TB burden in their own respective countries. I could quote examples of several countries who've been successful. Japan, for that matter, over the years has made a big difference. So the point I'm trying to make is how we can change our outlook towards bringing in more people towards carers. It can be an idea which can actually which may appear as not so important, but can actually make a big difference. So what the TB Mukt Bharat Abhiyan did was reach the unreached, reach the asymptomatic patients, asymptomatic high-risk groups, screen them, offer them handheld X-rays in remote areas like our Ayushman Arogya Mandirs, where handheld X-ray could reach in a mobile van, along with NAT, which was offered as a point of care. We've battery operated NAT systems, which were actually equipped on to these mobile medical units, so that following a screening and abnormal X-ray, these patients could be offered a NAT for diagnosis. This is where I'm actually talking about improving the diagnostics. And when we're talking about improving the treatment, again, some innovative ideas could actually help us. For example, a person who's on ART and, while on ART, because of, any issues, supposing the person is not taking any preventive treatment, in case a patient does land up with any symptomatic TB, or, for example, if he's not had any screening in the past, he could be offered screening in a bigger, in a more intensive manner, and offer treatment, anti-tubercular treatment along with ART, as you're aware that the guidelines have changed and the ATT has to be offered, as soon as the diagnosis is made, so that we do not, worsen the patient's condition. We do not let the patient's condition worsen. Going on to preventive as well, the efforts the National TB program in India has been putting for last few years has been for enabling the 1 HP preventive treatment for preventing our PLHIV from getting tuberculosis. But again, the reach of the 1 HP, of course, there is ample 1 HP stocked up all over the country. But then for each of our PLHIV to actually get the 1 HP. So here is where I come back to the role of community, our civil society, experts, our colleagues who are actually working on the ground. And I have, I request them all to come up with personal experiences which can actually make a big difference, to ensure that the preventive treatment, the 1 HP for preventing TB and PLHIV is ensured for each and every individual in the community who's on, ART, or who, of course, like I mentioned, early diagnosis would go a long way in enabling good care. So the role of civil society and the community has been alluded to by my dear colleagues, Dr. Lucica and the speakers before her, is something which is a no-brainer, like Dr. Lucica put it. But then I urge them to think a step further and actually bring their experiences to all of us, where things that are not being practically applied today are actually put into effect. So there can be something, a simple experience that our community people have, their own experiences, which can make a big difference in implementation. So I would urge them to share those experiences with the implementers to enable early diagnosis, better care, treatment to the best of its abilities, and prevention. So while I was the BDG, we were trying to work with the NACO.
We have lost you.
We, in fact, expanded our symptom, the classical 4S symptoms to expand to the 10 symptoms in order to, again, enable early diagnosis. So that was something that India did, and I'm sure several other countries followed. So these were experiences inbuilt into implementation, and that is my message to our civil society experts, our community leaders, that bring in your experiences to shape the implementation. With these words, I must thank you, Shobhaji. Thank you, the organizers, and thank you everyone who has cared to join us today to make a difference for the community, for the people suffering with HIV and those suffering with TB. Thank you so much.
Thank you, Dr. Singh. And your idea really worked and has brought about a dramatic and landmark change in India's TB response. We now move to our second session of this event, which will be chaired by Manoj Pardeshi from National Coalition of People Living with HIV in India, NCPI Plus, TAL Plus Healthcare and Community Pharmacy, NMP Plus. Welcome, Manoj, and over to you.
Thank you, Dr. Shobha. Thank you so much. Good morning, good evening, and good afternoon, your time zone. This session 2 is we dedicate to our great leader, Naresh Yadav, in his memorial as a PLHIV leadership. Welcome all speakers. Thank you, Shobha ma'am and Bobby Bhai, for bringing so many key stakeholders on one platform and initiating an important dialogue at very crucial juncture. We just finished HLM and we are now in between IS 2026. So there are lots of, I'm sure this discussion will lead and shape lots of policy level discussion in coming future. 2030 is not just a date or something like that. In 2030 we have globally we have aimed to end and eliminate number of diseases. So my question is it possible? And keep thinking, is it possible? To everyone who has joined, is it possible and how? Is it possible and how? With this note, I will start this important discussion. Just to quick reminder to all the speakers, we have 5 minutes time for you. Please abide to that time. With this, I would happy to introduce my best friend and Global Network of People Living with HIV co-chair, co-executive chair, Florence. Florence, over to you. Bobby Bhai?
Yeah, Manoj bhai, I think Florence has not joined yet, so please move ahead. Yeah, yeah.
You will follow up.
Yeah, yeah.
So
Yes,
I will
yes,
move
I'm
to the
following.
next speaker, our best friend and Daxa Patel, who is a founder member of NCPI Plus and now leading the National PLHIV movement. Over to you, Daksha.
Yeah. So, namaste, all leaders and partners who are joined here and who are already uh, connected to different places. Myself, I'm Daxa Patel. Yeah, I'm here with you all as a woman living with HIV, behalf of National Coalition of People Living with HIV. NCPI is a 1.5 million people's voice, face, and hope, and we are representing 20 plus state level networks and community leaders and community members to the grassroots level. First, let me give you answer, Manoj. Is it possible to end AIDS by 2030? Yes, it is possible because our more than 2 decades life is giving one of the best example. Uh, because we are here, HIV is like not death, but stigma, discrimination, and inequality is still there, which is the one of the barrier. We have just 24 months left to fulfill our promise to end AIDS and TB by 2030. The science is already with us, and treatment works, prevention works. And I proudly say that with living with HIV, I never transmitted my HIV to anyone. So that is one. I am one of the uh, person who is preventing HIV. Community-led response work. What we need now is the courage to put people first. Rethink. Let's start rethink our response. Stop like designing program for us, but take us in the designing program. We are not only beneficiary, we are a partner, leader, and part of the solution. Let's rebuild trust. No one should fear visiting to any health facility because of stigma, integrated HIV and TB services. Uh, this is the we have to set example on it, uninterrupted treatment, and make healthcare respectful, confidential, and accessible. Let's rise to our commitment. Invest in communities, protect human rights, fund what works, and listen to our life experience. Because when community-led outcome, that is give more results. And uh, my message is to everyone who are listening through this platform: don't count the next 54 months. Make the next 54 months count. The world does not need another declaration. It needs implementation, accountability, and leadership that puts people first. If we really truly want to end AIDS and TB by 2030, don't just include people living with HIV in the response. Trust us, invest in us, and lead with us. Together we can keep the promise, continue. I'm ending my message here, and thank you so much again, Bobby, Shobhaji, and Manoj for this platform. Thank you so much.
Thank you so much, Daksha. Really, you reminded that 54 months is remaining, because when we think about 2030, it seems too far, but it's just 54 months. Thank you. Thank you, Daksha. Now I move to Albertina Nyatsi. I hope I have pronounced your name properly. Albertina is from Positive Women Together in Action, Eswatini. Over to you, Albertina.
Good morning, everyone. As mentioned, my name is Albertina Nyatsi from Eswatini, working for Positive Women Together in Action, an organization for women living with HIV. I will start by saying community leadership means that people living with HIV and TB survivors are not receivers of care, but planners, implementers, monitors, advocates, and decision makers. And this enables us to reach population mixed by the health system. Why leadership of people living with HIV matters? As people living with HIV, we have our saying that says nothing about us without us, or nothing for us without us. And we are as communities, we are leaders and equal partners. People living with HIV understand community realities, lived experiences. They also are there to build trust, reduce stigma, improve treatment adherence, identify service gaps, influence policies, monitor accountability, and strengthen the health system. Our leadership is done through a lot of activities that we do in the communities, such as mobilizing and empowering women living with HIV to participate in national, regional, and HIV decision-making spaces, sensitizing parliamentarians on HIV and TB and related issues, and conducting meetings to educate them on other issues that pertain to HIV. We also sensitize traditional leaders on HIV and TB-related issues, because traditional leaders stay with the people in the communities. So there is need for them to understand HIV, TB, and related issues so that they can be able to ensure that the environment is conducive. We conduct community outreach and awareness activities to promote HIV prevention, treatment adherence, U equals U, stigma reduction, and TB case finding. We also are leaders in establishing of community support groups for women living with HIV, and providing psychosocial support to reduce isolation and strengthening resilience. The impact of our leadership is that the impact of our leadership is that we are able to change the health outcomes, and also we also have we also strengthen sustainable. We also strengthen health systems, and then also the community systems.
We are losing you, Albertina. We are not able to hear your voice. Albertina, are you there?
Manoj bhai, I think we can move ahead. Yeah.
Okay. Yes, go ahead.
Okay, I was saying the impact of our leadership include mobilizing and empowering women, sensitizing parliamentarians on HIV-related issues, and also conducting community outreach and sensitizing traditional leaders on bodily autonomy, HIV, and TB, and other related issues. We also established community support groups and for women living with HIV and other people living with HIV. And also we conduct safe spaces for youth and psychosocial support to reduce isolation and strengthen resilience. So what is it that is needed? We need, at the moment, we need government to fund community-led organization and recognize that people living with HIV and TB survivors as leaders. We also need to strengthen community systems, support community-led monitoring, and expand mental health services for people living with HIV and TB survivors, and also integrate HIV, TB, and SRH and social protection. And also the last one would be to ensure meaningful community participation. And then there is also need for to ensure that there is funding for community-led organizations. Okay, what is the impact of the service of the leadership for people living with HIV? The impact for this is that we were able to find more HIV and TB cases, and also to increase viral suppression and TB treatment success, reduce loss to follow-up, increase viral suppression, and then reduce stigma and discrimination. Because in our communities, we still need a lot of, we still have a lot of stigma and discrimination. Hence, there is need for those interventions. Ladies and gentlemen, I thank you.
Thank you so much, Albertina. You reminded us of integrating TB, HIV, and other health issues as a service package of HIV. Thank you so much. Now Florence, you joined. Just I will allow you to talk after the puja. Now I introduce Pooja Mishra, who is a young dynamic youth leader and who leads the India's Youth Lead Voices, a national HIV forum for youth living with HIV. Over to you, Pooja.
Okay, first of all, thank you so much, all respected chair, dignitary, and guests and everyone present in this meeting. Thank you so much for giving opportunity to present the achievements of Youth Lead Voices. I am pleased to share that Youth Lead Voices has made a significant progress in supporting young people living with HIV and at risk of HIV through the community lead intervention. Through our virtual peer support initiative, we have successfully identified 1,857 individuals through the peer case finding. We are also reported 27% HIV positivity rate through the virtual intervention, which is reflect the effectiveness of our target community based on the approach. We are reaching those who are the most need of HIV testing and linkage to HIV care. We also provide 1,156 young people living with HIV registered in Youth Lead Voices and creating a strong platform for a peer support. We provided mental health support, peer support, and continued engagement in HIV services. And which is a most important, 788 young people are achieved the viral load suppression, which is the significant milestone. Viral suppression is not only improve individual health outcome but also play the critical role in preventing HIV transmission in advancing the national goal 95, 95, and 99 targets. These are the achievement has been possible because of the dedicated our peer support and community partner, healthcare provider, and continued support of all the stakeholders. Thank you so much once again. Thank you so much, sir.
Thank you so much, Pooja. And happy to understand that the youth, when they reach out to the youth and peers through peer-led model, we get a highest success and highest result. Now I'm happy to introduce one of my best friend and a global face and voice of the PLHIV movement, Florence. Florence is Co-Executive Director of Global Network of People Living with HIV. And over to you, Florence.
A huge thank you to everyone. Can you hear me okay? Just thumbs up if I am being heard. So
yes, loud and clear, Florence.
Excellent.
Yes,
Thank
Florence,
you so
yes.
much for inviting me. And this is the most exciting pre-conference, as it has over 50 speakers today, so I will try to be short. I think I want to begin by just responding to what can we do better, by acknowledging that we have just come out of a high-level meeting that many of us at the beginning of the year did not even begin to think it would happen. Everything felt very uncertain. We are in huge moments of transformation, but thanks to the steadfast leadership of UNAIDS and a lot of the co-sponsors and everyone else, community pushing and working behind the scenes and on the front lines, we had a successful high-level meeting, and the political declaration has been signed by over 140 countries, cementing and solidifying the commitment towards ending AIDS and keeping people alive. I think we are in a good moment with that, depending on how you want to look at it. For me, that demonstration already shows that multilateralism is alive. It's alive for HIV, and we can leverage on it to move ahead. What can we as communities do to move forward? I think I just walked in as Albertina was speaking, and I just listened to Pooja now. Just to add on to those and just make 3 broad asks right now. I think people living with HIV, TB activists, people with lived experience must lead. We must stand forth right now to lead. We are in a moment of transformation. Ever since time immemorial, the HIV response has been led from our lived experience. We stood up to say we are here. We stood up to say we are facing stigma. Whenever we are told, oh, your information is not concrete, we sit down and we organize ourselves and we document. We stand up for each other. So I think this is the moment to lead, to show what is needed, to show what will work. And it needs to cut across HIV. It needs to look from a person-centered perspective, to look at across the course of life. We are people living with HIV, but HIV doesn't define us. The HIV response is transitioned now. We are away from emergency. We are moving to sustainability. What are the critical components that would be needed to sustain the response? That looks like young people beyond their diagnosis and looks at their reproductive ambitions and looks at their lives beyond HIV. What are the opportunities that we all can engage in pushing things like innovation? So we need to start leading in different facets. As countries are gaining ownership, we need to go back there and lead alongside our governments. Leadership is mature, leadership is collaborative, leadership is long-term, leadership is sometimes discussions and compromises, so let us lead. Number 2, we must lead with data. Our lived experience is data. We must not be shy to use our lived experience of what's working, what's not working. I think especially now that we are actually doing the HIV integration into primary healthcare and UHC framework, the 2 important people who are going to be at the front line of its honest truth is we people who are living with HIV, experiencing TB, malaria, or other infectious diseases, and the health providers who are taking care of us. Everyone else is going to be thinking about this from a textbook. We are the people who are going to be facing this and the realities of this change on the ground. We must lead with our data. Number 3, we must take the greater involvement of people living with HIV principles, the JIPA principles, the MIPA principles into integration. Services are getting integrated. HIV exceptionalism is ending. So how do we take JIPA into broader public health? We are the most organized community that everyone goes like, we want to learn from the HIV community. We want to learn from the HIV community. Now is the time to take JIPA into integration. As a person living with HIV leader, I challenge you to think about everything else within primary healthcare. HIV, TB, hepatitis, all of these infectious diseases, all of us are meeting at the OPD right now. It must work for all of us. The young, the aging, people with disabilities, key population, all of us are meeting in this one entry point. And we have 40 years plus of experience with working with healthcare workers, with advocacy, with community-led monitoring. that we can bring into these conversations. Broadly, I would like that we push for integration that works for people living with HIV sustainably. I would wish that we engage beyond the work as usual and start to think very, very organized ways of keeping our momentum and our movement alive. So what is the business of our networks? How do they stay sustainable? Countries are, in fact, if there's one thing I came out of the HLM for, is everyone was talking about investment in communities, and communities are important. I don't think anyone talked about how they will be funded. So if countries are saying they don't want to depend on donors and are looking for mechanisms for not depending on donors, can we begin to look at the business of our networks that would survive and be sustainable beyond donor investments? Finally, treatment and innovation is here with us. Innovations on testing that could power self-care are here with us. The opportunities are here. Can we build our knowledge, skill, capacity for advocacy, for market access, for motivating innovation, to not believe we need to stop at long-acting treatment? There is opportunities for vaccines and cure. I think there's a lot of work ahead of us, and we have so much to do to pass on a very strong movement to the next generation. Put people first. Let us rise and lead. Thank you and bye.
Thank you so much, Florence. Thank you for giving snapshot of HLM. And also you correctly said, like how our 3-decade experience will help to serve as a solution for lots of not only HIV with other illnesses also. And our role basically in stigma reduction and health system strengthening, it's something which is needed at this moment, especially when the funding is shrinking. Thank you so much. Again, I will keep reminding each and every speaker and participants, like, is it possible to end AIDS in 54 months? Keep thinking. Now, I'm happy to introduce our next speaker, Nelson Ottawa, who leads National Empowerment Network of People Living with HIV in Kenya, NEPAC. Hi, Nelson.
Hi, thank you.
Yes,
And
I
thank
hope
you
you
very much.
remember. Yeah.
Yes, I can hear you. And thank you very much for inviting me. And thank you very much for the introduction. My name is Nelson Otuoma. I lead the Kenyan network. And I want to share in the collective aspiration of communities of ending AIDS, or maybe keeping everybody alive beyond even just ending AIDS. But I just want to share that the experience from Kenya, there are populations that are left behind. And this afternoon or this morning, for those who are in the morning, I want to remind us of the plight of men, particularly heterosexual men, because men test late for HIV. Men also, when they test late, they also go for treatment late, and men also interrupt treatment. So the recent statistics show that men are the ones are leading in terms of AIDS mortality in this day and age where we have free treatment. But men also face the burden of TB, especially the age of 25 to 45. That is the burden of TB in our country. And this is also reflected across sub-Saharan Africa. So I wanted to echo the call of we need to work together to end all forms of HIV and TB-related stigma, so that men and other populations left behind, including key populations, can take up and utilize HIV prevention, treatment, and care, and make sure that they stay on treatment. But also, importantly, to look at the health of men broadly under universal health coverage, so that any barrier to accessing healthcare by men and other populations is eradicated or eliminated, so that we move forward together. And I also echo the issue of integration that is coming in now. And of course, integration is to make persons who have TB, persons who have HIV also benefit from universal health coverage, and to enable healthcare workers also check conditions of non-communicable diseases, including hypertension. So in as much as we are talking about ending AIDS and ending TB and moving forward, I think it is also important to look into other health challenges that communities and people living with HIV, particularly men, face. More importantly, in our region, we know that we've been responding to HIV, TB, and related conditions with external funding, and this came to a halt during the stop work order. And I know there are arrangements being put in place by government or government to government for funding, but they are coming back only with commodities. And therefore, it means countries, our country, Kenya, and the countries around this region and countries that still face the biggest burden must now invest and come in. And that is one of the targets that came from the UN high-level meeting on AIDS, 100% sustainability by 2030. And we are encouraging our governments and even local governments and national government to make sure that they allocate resources, and these resources are not just for procuring commodities and distributing them. The resources need to be put in place so that communities and people living with HIV are resourced, are empowered, and are capacitated so that they can also move to the level where they are in charge of their health. And talking about being in charge of your health, we have a strategy that now we are promoting in terms of self-care, and which means that we are able, those who are recipients of care are able to take care of themselves, prevent diseases, manage conditions that they have like HIV, and treat and cure conditions they have like, so that whether they are in the hands of a doctor full-time or whether they are on their own. And if we do that, even to prevent other conditions, then we are going to lessen and reduce and eliminate cases of being hospitalized. And we are also making sure that people adhere to their treatment so that, like in the case of HIV, treatment is prevention. Once people become undetectable, the chances of HIV getting transmitted is eliminated. Once people are doing that, then it means that is the only way we are going to make sure that nobody else gets HIV, and then we manage this epidemic. So thank you very much. Those are the insights from my point. I'm happy to come back and share if there's any specific question that somebody wants me to respond to. Thank you very much.
Thank you so much, Nelson, for touching critical issues on the access to first early suspicion, early detection, and then linkage with care. Thank you so much for your sharing your experience. Now I'm happy to introduce Sita Sahai, who heads Asia Pacific ICW chapter, and she is a strong community women living with HIV leader. Over to you, Sita.
Thank you so much, Manoj, and thank you to the CNS team for organizing this consultation in a timely manner. Good afternoon, everyone. It is an honor to join all of you today and speak on behalf of international community of women living with HIV in Asia Pacific region. I would like to begin with a simple question. If we already know how to end AIDS and TB, why are people still being left behind? The answer is not because of we lack the science. It is not because we lack the evidence or any tools. It is because too many people still cannot access the care and services they need equally, safely, and with the dignity. With just 54 months left to achieve a 2030 target, this is not the time to continue with the business as usual, as other colleagues also mentioned earlier. This is the time to rethink how we work, rebuild the trust with the communities, and find more resources, and rise together with the people, not the system, at the center of every decision. We don't want to be tokenistic in any kind of planning processes. For women living with HIV across the Asia Pacific region, putting people first means ensuring that every woman, regardless of where she lives or what she does, must access respectful, stigma-free, right-based health services throughout her life. Across our region, community people continue to face stigma in healthcare setting, discrimination within their communities, gender inequality, violence, and economic insecurity. Many continue to struggle to access comprehensive sexual reproductive health services, mental health support, TB prevention and care. Putting people first means dismantling the structural barriers that keep women and girls from care, which is far away to achieve in reality at the ground. What we need to understand is we can not separate these issues, whatever I have highlighted, and earlier our community people already highlighted. They are deeply connected with HIV response. When a woman is afraid of being judged at healthcare facility, she delays seeking care. We know that. And when she is excluded from decision making about her own health, she is less likely to receive the services she needs. Structural barriers such as gender inequality, war, injustice that prevent community from accessing HIV services that they need without fear, discrimination, or judgment. When community-led organizations are not funded, we lose one of the strongest forces for improving health outcomes. If we are serious about ending AIDS, TB, we must move beyond seeing the community simply as a beneficiaries, as previously Daxa also highlighted that, and not the number. Number is not a matter. And communities are leaders and experts in their own lives. They bring lived experiences, practical solution, and accountability. Lived experience means that we transform the life. You know, it is not the fairy tale. One lesson has been clear throughout the HIV response. Community leadership saves lives. We know that. We should not ignore the reality that community-led organizations build trust, where systems sometimes cannot. When formal health infrastructure cracked under the budget cuts, grassroots network and community-led organization stepped up to deliver medication and peer support as a mobilizer. Without further ado, I am really concerned with the timing. I would like to make 4 points. First, make the meaningful involvement of community in a reality, not only in the consultation, but in leadership, decision-making, program designing, implementation, and accountability. We are not a rubber stamp. We really need to be involved meaningfully in every sector. Secondly, address structural barriers, invest in integrated person-centered services so that HIV, TB, SRH services, mental health, violence against women, and social protection work together rather than isolation. Third, eliminate stigma and discrimination, punitive laws, and gender inequality that contribute prevent people from accessing care and exercising their rights. And finally, funds to community-led organization. I will repeat that word. Funds to community-led organization. We cannot expect communities to deliver lasting impact while asking them to do more with less or no funding. We all share the responsibility for the promise made in the Global Declaration, but our success will not be measured by the number of commitments that we made. It will be measured by whether a young women living with HIV can access care without fear and judgment, whether a mother living with HIV receives TB prevention and treatment when she needs it, and whether every person living with HIV can live healthy, dignified life and fulfill their life. Putting women and girls in the row. I mean, not in the option. It is not the option. It is essential to end HIV and TB. And lastly, a single word, I would like to repeat what Eamonn Murphy said. Let us use the declaration as a advocacy tool. Since the beginning, since the inception of ICWAP, I never saw the advocacy funding. Nobody fund for advocacy. So where is the funding? This is my question mark to you all. Thank you, and over.
Thank you so much, Sita. You highlighted 2 key points. Like still almost 30% people are not having access to the treatment. Besides, all the tools for HIV prevention, care and treatment are available. Secondly, the big chunk of 50% population of infected, which is women, and there is no woman teller service. So how best we can ensure that those services are there. Now I'm happy to introduce my last speaker, Media. I'm sorry if I pronounce your surname Khmelidze, who leads Eurasian Women's Network on AIDS and is from Georgia. Media, over to you.
Thank you so much. It's such a privilege to join you on this discussion and to speak on behalf of Eurasian Women's Network on AIDS, which unites 14 countries, more than 18 members, and it's the only network in ECA region who actually is run by the women who live with HIV themselves. And I'm here to bring the message once again, how important it is to reaffirm commitments to community leadership, human rights, gender equality, and meaningful involvement of people living with HIV. So many has been already said. At the same time, many of us who participated in the negotiations of the recent political declaration on HIV/AIDS know that important commitments on sexual and reproductive rights, decriminalization, and structural barriers were weakened. And on top of that, what has been already said, I really want to share why it's really important, utmost important for our region. Across Eastern Europe and Central Asia, women living with HIV continue to face multiple and intersecting forms of discrimination. Women who use drugs, women engaged in sex work, migrant women, women from rural communities, LGBT women, and women affected by violence often experience stigma and criminalization, not only because their HIV status, but because who they are, simply. And these inequalities are made worsen with the civic space shrinking, independent civil society being under pressure, and community organizations struggle to survive. So it's been a roller coaster during these last years for our region. The declaration recognizes the women living with HIV and them being disproportionately affected, but we need more transformative approaches that can only be achieved through sustainable community leadership. And we cannot expect communities to lead when they're constantly fighting for survival. The declaration set ambitious targets for community-led services, but for that, we need sustainable financing, and it was a very good point regarding not only to having this financing, but means of receiving and expanding them. For that, we definitely need safe and supporting implementing environment. While across many countries in my region, as I already mentioned, civic space is shrinking. Community organizations are working under increasing restrictions, reduced opportunities, including to participate in decision-making. And these contradictions must end. Community-centeredness, not an addition, is an essential part of TB and HIV response. Women living with HIV, those who use drugs, survivors of violence, other marginalized women often avoid services, not because they're not there, because of the fear of stigma, discrimination, breach of the confidentiality, and the criminalization. So what works? We all know what works. There is a lot of evidence on that. Community organizations help women navigate services safely, document their experiences, identify barriers, and build trusted referral pathways. Community-led monitoring is much more than data collection. It produces evidence that improves policies, programs, practices, identifies systematic gaps, and creates accountability, even when formal accountability mechanisms are weakened, which we experience in many of the countries of our region. And these approaches definitely work. Evidence is clear. So what is missing is not only the innovations, it's sustained political commitment and investment in community-led responses and the practices. Community-led response are not simply complementary to public health system. They are the only trusted entries sometimes and the points of care. And if we really want to keep the promise of ending AIDS by 2030, community leadership must be politically and financially prioritized in every country. Community-led networks and organizations need long-term, flexible, and direct support. Investing in community leadership is one of the most effective investments governments and donors can make. Communities build trust, reach those left behind, monitor the quality of services, defend human rights, and ensure that HIV responses remain person-centered, equitable, and accountable. So, taking that messages into account, I really would like to thank you for your continued support, and really we look forward for further collaboration for the sustained engagement in advancing our shared objectives. Thank you so much.
Thank you so much, Media, for highlighting the political commitment issue. So just for the group to share that in current HLM, Florence said that 149 countries voted for the declaration. Surprisingly, 8 countries was against, and America is one of the country who against the political declaration. This is not a good sign for ending AIDS. And that's what I keep reminding again and again. Is it possible to end AIDS? So thank you all speakers. My closing remarks is nothing changed when communities are only consulted. Me and Florence were there in the HLM, and everybody is talking the same thing again and again, that we need to engage community, we need to engage community, but nobody is talking how, where, and everything. It will not work. Nothing will change when communities are only consulted or just mentioned in declaration or in strategy papers or slogans. Everything will change when communities are trusted to lead, allowed to play a role in designing, delivering, and driving the response. Thank you, everyone. And now I will hand over to our best friend, come doctor, Dr. Rewari. Over to you, sir.
Excuse me, can I just intervene, please? Dr. Rewari will be chairing our next session on community and key population-led high-impact HIV and TB interventions. Dr. Rewari wears many hats. He formerly led the ART program of Government of India's National AIDS Control Organization. He is also former WHO Southeast Asia Regional Advisor for Viral Hepatitis, HIV, and STIs. And currently, he is visiting professor of epidemiology at Institute of Liver and Biliary Sciences of Government of Delhi, which is a WHO collaborating center for viral hepatitis. Over to you, sir.
Thank you. Good morning, good afternoon, everyone from global community across the Asia Pacific, Africa, and Europe. Thanks to organizer for organizing this important event, and special thanks to Bobby, Shobha, Manoj, and others for taking the lead in organizing this session. As we bring this deadly moving, powerful session, the previous session, we must first basically congratulate you for dedicating this session, the previous session, to memory of Naresh Yadav. Naresh Yadav's legacy reminds us that fight against HIV and TB has never been about clinical protocols or statistical milestone. It is fundamentally about human spirit, dignity, and right to health. So that is the message the community has conveyed time and again. But again, business as usual will not work. It will fail us. That is what came from a high-level meeting just recently. It is good that we are now counting in terms of months and not in terms of years. I think that is a change that we have. So basically on this session, as we move to this session, I will focus basically more on the scaling up of the community and key population-led high-impact interventions to bridge the divide. Before I begin the session, I would also like to focus basically on what Eamonn reminded us today, that it's not only 95, 95, 95, but also not to forget 30, 80, 60, which many people even don't know, and 10, 10, 10 also, which has been talked about recently. This specific session is dedicated to bridging the divide by focusing on real catalysts of change. That is the community and the key population-led interventions. I know in India and many other countries, communities have never been taken as just beneficiaries. The communities have been at the forefront of the response, advocacy, working closely with the national programs, working with civil society, and communities have been primary drivers of health system resilience and accountability. So in this session, basically, we will have 19 presentations, a big number, but I feel these are quite representative. And these presentation will feature some leaders, community organizers, public health experts. And if I see, it includes countries like Thailand, Indonesia, Bhutan, Cambodia, Philippines, India, Uganda, Botswana, Zimbabwe. So what we expect to learn from these is basically to look into some of the key population-led health service models which are embedded within the national program, innovative harm reduction strategies, particularly for LGBTQIA, because there are complex regional transitions, high-impact youth-led interventions, initiatives, which can lead to near-perfect viral suppression, point-of-care models, AI-enabled X-rays, solar-powered molecular diagnostics to reach most vulnerable in remote areas, in islands, in countries, the resilience of the community in countries like Myanmar, which have gone through earthquakes and other natural disasters. And there is a proof that targeted system strengthening can bring down the state-level TB burdens and HIV burdens to near eliminations. So just a note to the presenters that you have maximum 5 minutes. You will have a Zoom countdown also available on your screen, as I have been told. So kindly tailor your presentation around 4 questions which must have been circulated to you. What is your high-impact community-led intervention? What critical gap that intervention has filled? How it was implemented? What impact came? Because this session is important, listening to you, this sets the stage for the next session, where we'll have representatives from WHO, Global Fund, UNAIDS, and other ministries of health. So to begin this session, I will invite our first speaker, Nutrapat, Director of MPLUS Foundation, Thailand, to share how key population-led PrEP interventions and HIV services delivery has successfully integrated into the government programs. Over to you.
Hello everyone, my name is Nat and I will share slide on the screen right now. Okay, everyone can see my slide?
Yes, please go ahead.
Okay, so let me introduce myself. My name is Nat Nathapat Vajasuwan. I'm online activities communication supervisor, experience 3 years, almost 4 years. Yeah. So let's talk about the little of background of Empath. We are the community-led health service. The evolution since 2003, Empaths have evolved from HIV prevention initiation into the trust community-led health organization through the foundation registration, government partnership, and social contacting. We have continuous expand our service in today. So right now, M Plus, we provided one-stop service help that included the diversity needs of our communities right now. So we're working 6 provinces that have drop-in center. That's Chiang Mai is the head office, and we have Chiang Rai, 3 medical technology clinic at Chiang Rai, Phitsanulok, and Nakhon Ratchasima. And we have drop-in center in Lambang and medical clinic in Bangkok. And also we're doing the mobile VCT service in 7 provinces. So let's just talking about the PrEP service model that we doing for the high impact intervention. So we have PrEP service on drop-in center and the mobile clinic. In the PrEP service model, we expand equitable access into the HIV prevention. In the clinic-based PrEP in drop-in center, we provide PrEP service the same day prep in our clinic. We have the strong collaboration with the local hospital. We have the standardized SOP and referral pathway. We have the data. The past 4 or 5 years ago, we didn't know for the CBO. We didn't know for the implant. The hospital, they didn't know who we are. So we just created the data, and we going to connect with the local hospital. So right now we have the standardized SOP to do the trustworthy for the local hospital. Right now we have strong collaboration in our province. So the key strength that I just earlier said, because we have the strong collaboration, we have the standardized SOP, we have the client-centered services, and we have the data to drive in this to make the government refund and have the trustworthy to our services. And also we have the mobile clinic prep. So we just doctor says on the previous session, we have the prep telehealth that integrated online and offline services for the new intervention and follow-up system. So improving access for people in the remote or underserved area. So we have created the model. So we have the PrEP model. So right now, currently pilot in Chiang Mai. So the key strength, we got a telehealth enable follow-up and local laboratory and hospital networking and the convenience to our services. Yeah, the PrEP telehealth is bridging the gaps, connect the online and offline service, ensure credibility, access, continuous care, and get it convenient for PrEP client. So this model reduce barrier and improve the convenience and support the long-term adherence while maintaining clinical safety. So just a little bit of number. So the number of national PrEP in Thailand, we M plus PrEP for performance, we do 12.04% of PrEP, the new PrEP initiated by this model to our community. And also we doing in the prisoner in northern Thailand. So just a little bit of wrap up. So we bridging PrEP closer to people wherever they are. No one is left behind. And we also doing the technical support in our EPIC countries, so Laos and Myanmar, and we have training package. If any one of you want to learn more and want to do learning from our foundation, so you can contact M Plus Thailand or me directly. Thank you.
Thank you, Nat, very much. And I like your conclusion that we should reach wherever they are, even for PrEP. The DIC model, the prison model, and the mobile model, these are very good examples of reaching out and filling the critical gap. Thanks for your presentation. I'm pretty sure this one intervention which has got significant impact but is not scaled up to the required level. Maybe the injectable Lenka in future will provide that, fill the gap also, because it will be available at a cost of $40 and will be also in part of the Global Fund grant programs. Thank you. So we move on to the next speaker. Next speaker is Dr. Nicole from Euro-Asian Coalition of Health, Right, Gender and Sexual Diversity. And she will present in context of LGBTQIA, rights, sustainability and Global Fund transition as a broader Eastern European perspective. Over to you, Nicole.
Sir, please move ahead. I think Nicole is not there online right now.
Yeah. I don't think we see the next speaker or the slides.
Yes. Yes, sir. So Nicole is not there online. So you can move ahead to Manoj, sir. Yeah.
So we move to Manoj. Manoj is a friend and has been associated with Indian program for years now. He has got many large contributions to the Indian national program, to the community. But what he's going to present today is basically, I think, he founded TAL, a pharmacy where you had quality drugs at affordable prices for people who could not reach to national program for various reasons. And he presented top social enterprise models at the 25th International AIDS Conference. Over to you, Manoj. Look forward to listening to you.
Thank you so much, Doctor. Thank you. Bobby Bhai, can you please? Yeah. Okay. So, thank you, Dr. Rewadi. TAL is a treatment adherence, advocacy, and literacy. It's a full form of TAL. Basically, the TAL born when HIV treatment was not there in the year 2000, where first time I came to know about the concept of Bias Club, and that's how the TAL concept evolved, and we started advocating for that. The first TAL we set up in Pune is in 2006. So it's basically the initiative for the people, those who are accessing care from private and those who are not able to reach to the services. So how services can go to them by ensuring the peer lead model. Next slide, Bobby. It's a stigma-free access. During COVID, we moved from physical pharmacy to digital platform, and then from there it became a sustainable model, a social enterprise model for the CBO. Next slide, Bobby. So the growth, if you see, is almost 800% in next 2 years, last 2 years. From 3,800, we moved to 36,000 per period. This is a huge jump, and simultaneously it reflects that there is a huge need which is there, and we need to think innovatively and to take the services till last mile. Like 36,000 people is reach. 14,000 has care access. Our revenue is in last 3 months from the website, from the e-commerce, is somewhere around $2,000, and our reach is in 25 plus countries. Our largest orders are from India, but apart from India, the second largest orders is from Africa region, and then in Asia region and US region. Next slide, Bobby. Next, this is already a. So, sorry, Bobby, previous slide, please. Okay. So here I want to highlight that 14,000 plus doctor consultations has been done. It clearly tells us that we need a doctor's availability whenever we need. The facility base is basically, it has certain timeline, and in the countries like India and most of the Asian region and Africa region, the doctors is not available every time. But the virtual doctor consultation is huge demand, and that is something the program needs to think that how we can make available a quality consultation whenever it is required, and it's possible through the today's digital era. Next slide, Bobby. Next. One of the second biggest need is basically PEP and PrEP. So we all are talking about PrEP, and we know the importance of PrEP is happening. But simultaneously, I also want to highlight there are so much demand for PEP also. And for PEP demand is just not medicine. It's a huge confusion in people's mind, huge fear in their mind that what will happen to me now. And all those are also related to the good quality psychosocial counseling, making them comfortable, educating them on all prevention method and safety methods, and simultaneously ensuring that they should get the PEP either before 2 hours or 72 hours. So that's one of the biggest learning for us. We have almost equal requirement of PEP. It means people are still not practicing the safe practices. Next page, boy. Next, this is all the revenue, so people might not much interested. Okay. So here also we basically create a platform to people, those who all exposed to risk or those who are at risk. And this basically, you see from community grinder, we have direct people reach. The green is from the virtual platforms. The organic reach is in brown color. And then the paid search is like somewhere from the e-commerce platforms, and then the black one is a referrals and all those. The point here we are making is that the virtual intervention is also equally important to take the services till last mile. Next one. So this is again regarding the search. So these are the few medicines which is frequently searched. Tenofovir EM. So basically for PrEP there is a search. For HIV medicine there is a search. These are the keywords which people use for searching the HIV medication. Next slide, Bobby. These are some cities where we get the traffic. Next. So again, this is some like how many responses we handled, considering the time difference and everything. Still, we are able to handle lots of services. Our current challenge is basically the timeline. When people from outside India reach us, that time our office sometimes get closed, and we don't have still. We all know that funding is an issue, so we don't have that 24 hours helpline and all those backup support to cater to the global responses. Next slide, Bobby. So again, as I said, like almost this is $2,000 plus is a self-generated revenue. As I said, like it's we have almost 800 times jump in the like services. People reach to us and they avail either counseling, either doctor consultation or medicine. Almost we are able to save more than 70%, as we know that the model is as such that where every service is very highly subsidized service. So even say the medicine, the ARV medicine, which is costing say somewhere around $50-60, it's available at $10 or $15. And same for all other services, whether it is viral load or routine diagnosis and everything. Next slide, Bobby. So the current, we all know that the HIV infection is rising in key population, and are we actually reaching to them as a prevention mechanism or treatment mechanism, or the biggest mental health and counseling mechanism? And all these services, are we taking to them wherever they need? Because mostly this population is now working population, and they don't have time to come to the service. So this is the one initiative where we can take service to them. Telecounseling and adherence support is the happening thing, because people don't have a time to travel. They don't have sometimes that much energy to come. But telecounseling is something people keep, like our highest call is almost 2 hours when a person keep talking to our counselor. And most important is adherence support. Like then whatever questions they have regarding the medicine or side effects and adherence, we need to we are available to cater to them. And each our outcome is measured and upgraded. Each our call is recorded so that next time we can improve on that. Next slide, Bhavin. So it's a proven reach and increasingly self-sustaining model. I request like UN agencies, WHO, and people like support us in scaling up this model so that CBO, PLHIV CBO will be sustained. They can have their own revenue generation. Plus, it's not only revenue generation, it's the peer-led response where we can help in reducing self-stigma, acceptance, continuum of care, maintaining good adherence, and also simultaneously motivating people for testing and leading a positive life. Next slide, Bobby. Let's keep building access together. Thank you so much. Thank you, Dr. Everybody.
Thank you, Manoj, for an overview of TAL Plus, basically the support which reaches and resolves, rightly said. So we congratulate you on the increase of almost 800% over time. So we move on to the next speaker. Do we have Nicole? Can we check? Bobby, can we check? We have Nicole, or we move to the fourth speaker?
Then we move to Numan, yeah.
Okay, so we have Newman Afifi, Program Advocacy Lead at EPCOM based in Thailand, who will present basically on high impact key population-led intervention among MSM. And Bobby, I noticed that timer at the top was not running in the previous session. It was there in first session.
Right, sir. It will be back now. I'm sorry.
Thank you. Yeah, it's there.
Thank you, Dr. Ravari. Greetings, everyone from Bangkok, from EPCOM in Bangkok, to everyone in Delhi and who's joining online. I have 5 minutes, so let's just get straight to it. I want to tell you what happens when HIV testing campaign stop lecturing to young people and start speaking on their language, literally. So here's the gap that we set out to close in Asia Pacific. So when we started, cities like Bangkok, Ho Chi Minh City, Jakarta, Manila were reporting HIV prevalence among gay, bisexual, MSM of between 15 to 31%. Yet, when we look at the data, fewer than half of these young MSM, aged between 18 to 29, have ever tested for HIV. So you must be wondering why, because the whole generation, even today, have moved online. So young people were meeting partners on apps and social media. So no longer cruising at physical hotspots where outreach workers used to find them. In the meantime, health messaging mostly stayed clinical and fear-based. And because of that, fear of being judged, at the facility, many have kept away. So those services didn't move where young people actually live their lives. So that was the gap. So in 2014, APCOM piloted Test SSX in Bangkok. So Test SSX has a slogan that I can say out loud at this event. Pardon my language. Suck, fuck, test, repeat. So this slogan tells you everything about our approach. Our approach is sex positive. It's funny. It uses the community's own word, and it exists in platform that young MSM already use. Facebook, YouTube, and dating apps like Grindr. So this model is simply online to offline journey. So what we do is first we attract by using provocative content that dissociates testing from fear and stigma. And then second, we engage them through online outreach that answer question and hand holding, first time who are nervous about testing. Third, we then refer them directly to MSM friendly community clinics with online bookings where possible for testing, for prep, for treatment. And then lastly, we repeat. So clinic would share their service data and then it feed straight back to the campaign. So what most critically in every city, these interventions are community owned. So in Manila, we have Hash, we have Love Yourself. In Saigon, Ho Chi Minh City, we have Karma. In Jakarta, we have GWL INA. In India, recently we work with Hamsafar Trust. So what APCOM does is we provide the brand and technical guidelines, but it was the community themselves that runs the campaign. So even the slogan will be localized to each cities. So in terms of impact, did it work? So across 4 evaluated cities, Test SSX campaign has contributed to almost 40,000 young MSM that got testing for HIV and know their result, and more than 3,400 that were positive were enrolled directly into treatment through our partner clinics. So in Bangkok, the awareness campaign has tripled when one of our web series on YouTube, you can watch, Gay OK Bangkok, have reached 2.5 million views. So PrEP awareness because of this campaign has rose from 51% to 90%. And until today, this model work. So under Code Strategies Program under Elton John, its foundation, our committee-led demand generation have recently reached over 41,000 people across 6 countries in 2024, which is 127% of target. So I just want to give 4 lessons for this room. Number 1, pleasure beats fear. So entertainment carried our health messaging further than fact-check ever did. Number 2, community ownership is the sustainability plan. So local organization, creative and influencers carry the campaign beyond any single grant. Number 3, digital needs human companion. So hesitant first-timer need a person to talk to, not just a post to scroll past. And lastly, for online, whatever we do online must land offline. So digital demand only works if it wired into a trusted, judgment-free services. So thank you for giving me for lending your ears. I'm happy to connect to talk more about the campaign.
Thank you, Newman. So in interest of time, we move quickly to the 5th speaker, that is Bella, a transgender woman who is the chair of the Global Fund Youth Council. And I think we'll be able to listen from her about the young key population and young people living with HIV in decision making. Over to you, Bella.
Thank you so much. Can you hear my voice clearly?
Yes, clearly.
Perfect. Yeah, I think I will not very long because my colleagues Numan is already telling the best intervention that currently happen in ASEAN Pacific. I just want to share something that I think is really important, especially for community intervention. Based on reflection, it is important when it comes to making intervention for HIV, especially by considering this community system, which we can see that there is demand generation and also peer outreach to create awareness, trust, and also motivation to test. We do this intervention by social media and digital engagement. We also do youth festival and community event, and also HIV literacy and risk perception. Also, after we create the demand, we also need to make sure about a safe and enabling environment for youth to access HIV services, and making sure that HIV testing is accessible, acceptable, and youth-friendly. And we are having intervention for a point of care and also decentralized testing service. We do some hotspot and door-to-door engagement. So door-to-door services is still needed and as a best practice in Indonesia, because we are a very large country, and it's really difficult for some cities to go to health services because it's far away. So door-to-door services is still needed by the youth in Indonesia. And also extended clinic hours for adolescent and young people, because we know they are going to school, and it needs to be extra hour for them to access HIV services, and also mental health and psychosocial and paralegal support as well, and also system change and community leadership. When it comes to these services, it needs to have a community-led monitoring as well to see the quality of the services, so community could give some feedback, and also policy advocacy as if we see the CLM data and result, and it needs to be to do some advocacy with the District of Health or Ministry of Health. It should be done to make a system change, and also bridging providers and communities together. Because again, before people, our community trust system marginalize young population trust communities first. Yeah, so what I want to talk about is the structural invisibility of young population, especially in Indonesia. In Indonesia, HIV response targeted key population broadly, but lack targeted infrastructure for young population age under 18, which from horizontal infection, not from vertical infection. And if you can see, there's a missing wage, which is young population under the age of 18, which the age of consent in Indonesia is 18. And this is the challenge, which is clinic hours incompatible with school schedule, also fear of disclosure to family or guardians, a lack of adolescent sensitive HIV service, and also limited youth specific peer support system. And the consequences of this, it obviously untested, it will be untreated and also lost before linkage to care. And the young population under 18 remain high vulnerable here in Indonesia, and it's still invisible within the standard HIV programming. So what I want to share is sometimes we forgot that community advocacy is also the very effective intervention beside all this innovation with technology and AI or other innovation, but still community advocacy is something that we still need, especially in the country that still have policy barrier needs to address, because if not community who could advocacy it, who will be? So community advocacy is really important, and in the context of Indonesia, before 2022, many young population face significant barriers in accessing HIV testing, because previously they only could access HIV testing with parental consent, which it's difficult for them to bring the parents, because the parent will be mad or being discriminated about it, because it's about HIV, and HIV it's very stigmatized. And this this is the advocacy that we do in Inti Muda, which is we are passing this Minister of Health regulation that allow not only parents who could be a guardian for under 18, but also community and also outreach worker could also has a companion. But again, this policy is available, which inclusive for under 18 to get tested, but it's the implementation is not always the same. So this is the challenge that happened, which we are still needs to do another advocate, which is to have a dairy freight regulation, which is a circular letter to be sent to all health services in Indonesia. So the health services should know that under 18 young KP could access HIV testing. And this process took a really long time. And before we do an intervention, it's something that we need to change is the policy barriers. It's if there is a policy barrier. So this is something that we are still going to do, which is we are waiting for the circular letter from the Minister of Health to be sent to the health services, so they will allow under 18 to get HIV testing. And it's been 4 years since we are advocating it. And yeah, it's something that we need to be addressed. And I hope maybe in another country, if it's still barriers, advocacy still need to do. And most donors sometimes not recognize that advocacy work is not necessary or it's not important. But again, it's still important for community to do advocacy works, because community are the one who could advocate it, because otherwise no one will help us to advocate it. Thank you so much.
Thank you, Bella. That was excellent. You not only highlighted the gap, that is the missing wedge of less than 18 years, 18% of KPs under 18 years of age, invisible but vulnerable. Then you highlighted what were the action taken, policy, Article 29. And now how are you supporting the implementation of this Article 29? So that is the work you are doing, really commendable. Thank you very much for your presentation. We move on to next very important topic. And that topic, basically, we know that people who are homeless or migrant, they have got issues in accessing testing, treatment services, retention in care. But we have now example from Humana People to People India, where they have shown that treatment completion rate for TB in this group of population can be equivalent to the general population, that is as high as 90%. With hardly any loss to follow. So Dr. Sugata is going to take us through the concept and how they did it. Over to you, Dr. Sugata.
Good morning, good afternoon, distinguished chair, colleagues and friends. I am Dr. Shubhato Mukhopadhyay, Public Health Advisor of Humana People to People India, or HPPI. HPPI is a national level NGO operational in multiple states of India, where health is one of our major intervention areas. Today, I would like to share our experience of integrating TB and HIV services through community platforms and why this approach is essential if we aim to reduce TB-related illness and deaths among people living with HIV. Although India has made remarkable progress in HIV care, significant gaps remain. India is home to an estimated 2.56 million people living with HIV, the second largest globally. About 1.69 million are receiving antiretroviral therapy, and most of them have also initiated TB preventive treatment. However, this still leaves an estimated 900,000 people living with HIV outside these essential services, making them much more vulnerable to tuberculosis. Every year, around 45,000 to 50,000 people living with HIV develop active TB. And TB continues to account for about 1/4 of all deaths among people living with HIV in India. These figures highlight an important reality. TB and HIV are closely linked diseases, but too often they are managed through separate programs. Patients experience both diseases together, so our health services must also work together. Service integration is therefore not just desirable, it is essential. With this vision, Humana People to People India integrated TB services into its existing HIV, targeted intervention and link workers scheme projects in Delhi, Lucknow and Unnao in Uttar Pradesh and Kota in Telangana. Rather than creating a new program or recruiting additional staff, we strengthened the capacity of our existing HIV outreach teams. They were trained to conduct TB symptom screening, educate communities about TB and HIV in the same sessions, reduce stigma associated with both diseases, and establish strong referral linkages with the National Tuberculosis Elimination Programme for diagnosis, treatment, and TB preventive treatment. This approach demonstrated that integration can be achieved through routine program activities using existing community platforms, making it both practical and highly cost effective. The results over the 5-year period from 2020 and 2025 were very encouraging. Among HIV high-risk population, more than 113,000 individuals were screened for TB symptoms. As a result, 671 people with TB were diagnosed, initiated on treatment, and all successfully completed treatment. In addition, 433 eligible household contacts completed TB preventive treatment, helping to prevent future TB disease. Within our people living with HIV cohort, we screened about 500 individuals, diagnosed 11 TB cases, initiated treatment for all, and 301 individuals received and completed TB preventive treatment. However, I believe the most important outcome is not simply the numbers. The most important lesson is that these results were achieved without establishing parallel system or requiring major additional resources. By strengthening the skills of existing frontline workers and integrating TB activities into routine HIV services, we were able to substantially improve access to TB screening, diagnosis, treatment, and prevention. The model also offers another important advantage. Community outreach workers already have the trust of vulnerable populations. When they provide integrated services, they reduce missed opportunities of early diagnosis and ensure that individuals receive more comprehensive care through a single trusted platform. As India moves towards the goals of ending TB and HIV, community-based service integration offers a practical way to strengthen both programs simultaneously. In conclusion, our experiences demonstrates that TB-HIV service integration is feasible, effective, and scalable. It improves access to care, strengthens collaboration between programs, increases uptake of TB preventive treatment, and ultimately saves life.
Thank you, Sugata. We know that the integrated approach is the way forward, not only for TB and HIV, but for all eliminable diseases. We have been talking of HIV, STI, hepatitis, TB, but I will say other eliminable diseases also should be included in that. So we move on to the next speaker. Next speaker is Ghana, Executive Harm Reduction Association based in Lithuania, and she will present on perspectives of persons who use drugs, as well as Eastern Europe and regional context on harm reduction. Over to you, Ghana.
Thank you, Chair. Could you hear me?
Yes, Claire. Please go ahead.
Hopefully. Yeah, I'm sorry for presenting such fast because I'm in Geneva going to some Office of High Commissioner, but nevertheless, I'm very happy to be with you and to have such broad overview of the necessary points and necessary recommendation to end AIDS till 2030. And I'm from Eurasian Harm Reduction Association. And that's the membership non-for-profit public organization based in Lithuania and uniting harm reduction activists and organizations from Central and Eastern Europe with a mission to actively unite and support communities and civil society to ensure rights and freedoms, health and well-being of people who use drugs in our region. And I need to say that Eastern Europe and Central Asia remain the only region where HIV epidemic continued to grow and death rates continue to grow, mainly because the country with 70% of new HIV cases and highest epidemic rates and burden among people who use drugs, actually banning opioid agonist treatment by law and saying that and claiming that harm reduction is a Western dangerous influence. And this country, unfortunately, as being ancient empire and country aggressor, authoritarian state, not only killing their own criminalized and marginalized people, but also pushing all neighboring countries to stop providing harm reduction. And that's the saddest story of the region about the efficiency and possibility to stop AIDS, because if political decisions will not be made in Russia, then we could not stop AIDS in our region. And being from Ukraine, a post-Soviet country, I remember repressive psychiatry compulsory narcological services that functioned like gulag forced labor camps, not healthcare. But during the last 30 years, civil society, communities and professionals transformed the system into evidence-based services responding to real needs of people who use drugs. And actually, majority of governments already recognize necessity of harm reduction. But what we learned from experience, and we have harm reduction introduced in majority of 28 countries of Eastern Europe and Central Asia, but what we understand from implementing of the services and trying to make the coverage sufficient to respond to HIV, hepatitis and TB. First of all, we understand that we need to put human rights in the center of HIV response, and we need to highlight decriminalization of drug use and possession as a first barrier which stop people criminalizing and stigmatizing of people who use drugs. That's the key barrier which stopping them to be tested and to get treatment, to start PrEP. And all other health services. Actually, that's the key barrier which stop people to approach any public services, health services, social services. And that's why we are very happy that the Political Declaration 2026 reaffirming 10-10-10 targets to overcome the barriers and first of all the punitive laws. And what is important that right now in 10 minutes we will launch guidance note on decriminalization of drug use in the context of HIV, which was developed by UNAIDS, UNDP, and co-authored by International Network of People Who Use Drugs. And that's actually the methodology how to make the criminalization work for HIV response effectively. The second recommendation, it's about the comprehensive harm reduction. Harm reduction is not only opioid agonist treatment, which easy to procure for governments and easy to implement as a medical service, but actually it's not only opioid agonist treatment. It should be combined with needleless syringe exchange program for injecting drug users, but also harm reduction information and drug checking for non-injecting and stimulant users, community-based HIV and hepatitis testing services, overdose prevention, which is very crucial as for now, using naloxone for opioid users and fentanyl strips to understand if drugs consist opioids, fentanyl. And also we are developing, and we have plenty of integrated services. So just to finalize, we need to invest in community-led services, in contracting civil society organization, community-led organization as equal partner in providing services. But in the same time, I need to reiterate what was said before, that advocacy funding, community-led monitoring funding is the crucial for effective HIV response among key criminalized and marginalized populations, especially in the context of the shrinking civic space and challenges with the so-called foreign agent law, undesirable organizations law, and anti-drug propaganda law. This all legislation actually trying to kill civic space and trying to restrict the funding, access to advocacy for civil society, and actually killing and making not possible response. So my conclusion is that remaining barriers to respond to HIV AIDS till 2030 is political, not technical. So as soon as we have free civic space, supported civil society, and decriminalized drug use and possession, and comprehensive harm reduction, we could end AIDS even faster than 2030. Thank you very much, Chair.
Thank you, Ganan. That was very powerful presentation, basically highlighting the key challenges and constraints with some of the resolutions and community-led fundings. But it is good that 26 high-level meeting has highlighted 10-10-10 again. And though the sad part was only 149 countries actually really endorsed the resolution, that was a big setback, I will say, compared to previous high-level meetings. But anyway, it's always a process. Thank you very much. That was great. We move on to the next speaker. That is Dechen Wangchuk from Bhutan, presenting on young key population and youth-led interventions. Over to you, Dechen.
Thank you, Chair. Hope I'm audible here. Okay, so warm greetings, everyone. Warm greetings from Bhutan. So I am Dechen Wangchuk. I am from a youth-led organization called as YPR Asia Pacific
I can't
Center.
hear you very clearly, Dechen.
Sorry, okay.
And I don't see you or your slides. Do you have slides?
Wait a second. I don't have a separate slide.
Doesn't matter, but I don't see you. Okay, please speak closer to the mic.
Sure. Okay. Am I audible right now?
Slightly better. I don't know about others. Slightly better.
Okay.
Yeah. Please go ahead.
Hello, everyone. I think
I'll
I'll just
increase my volume. Yeah.
Sorry. Am I audible?
Yes, better now.
Okay, so I'll keep my camera off in order to have a better connectivity. So I don't have slides as such, but I'll be sharing some of the insights that I have throughout my journey as a youth volunteer with the YPR Asia Pacific Center.
Yeah, thank you.
And aside to side, I'm also working here in Bhutan with the young key populations, such as people living with HIV, people using substance and substance people with substance use disorder and alcohol use disorder, and also female sex workers and LGBT plus community in Bhutan. And to just straight away go into the discussion and just to share my insights, I would like to say that as a youth advocate and a youth volunteer from YPR Asia Pacific Center, I have served in building and strengthening the capacity of community-based HIV service center. So in Bhutan, we basically function the HIV prevention services from the community itself. As we all know that HIV and the key populations such as LGBT plus are still the taboo in the community, and we are not yet fully backed by the legal, and especially the female sex workers who are vulnerable to HIV infections, but they are yet not recognized and criminalized for their profession. So we worked quite closely with the key populations, but in a community-based center with a very unstable and volatile political environment. So we, in the community-based center, we do have interventions such as providing HIV self-testing kit and providing contraception such as condoms and lubricant. And we do had recently introduced PrEP as one of the a medication for the highly risked populations such as LGBT plus community, and specifically the men having sex with men and transgender women with the necessary medications such as PrEP. And we've been emphasizing PrEP in a large. And then also the community, we work closely with the community organization and work as a referral agent to the members, community members, to refer them with the in-depth clinical procedures and help, such as recommending or providing them with hormones for the transgender women, and also for the men having sex with men to know their status, such as HIV status, and also STI testings, and to know their sexually safe and healthy. And then to go now with our implementation method, or how we are implementing these activities so far is that we do use community mobilization as one of the effective approach in reaching the community members across the country and from every corner of the countries. To first of all, we do mobilize some of the outreach health workers. We work with them simultaneously to reach the marginalized populations and vulnerable populations to be part of the effort, and also to advocate and give awareness on some of the healthy sexual lifestyles. And finally, upon getting all the community members on board and being part of the community, after joining the community, we tend to provide a demand generation programs in order to help them access the services available in the community and also in the community based service center. And that's how we were able to onboard and those community members to properly utilize their services to the fullest. And also now in the third, I think I would like to now talk about some of the impact that I have seen or enlarged in a programmatic manner. So first one, I would like to say that the impact has been great in Bhutan specifically, and I would say that because of our collaboration with the key populations, we were able to advocate more on the inclusive and sustainable health systems. And now with the government, especially Ministry of Health, under that national control for AIDS and HIV and AIDS program, has been emphasizing a lot on creating inclusive health systems, whereby they are training health officials on providing one-to-one sessions in a non-discriminatory way, and how to responsively provide a consultation to the community members who are vulnerable who are at high risk of HIV infection. And also we do have we could also witness and see and feel that the health officials are being very respectful and creating a respectful environment and comfortable environment for the community members to come walk in and avail the services, so that they could be safe wherever or anytime. And also we were able to now foster community forums with open discussions on sexual and reproductive health and rights, which also in a way contributes to the efforts of preventing HIV. And finally, I would like to say that the YPR has a national training of trainers module, which trains on sexual and reproductive health and rights on the upcoming youth advocates. And during that time, because of our partnership with the community and all development partners such as Save the Children, who were able to bring the PrEP medication in Bhutan, we were able to integrate the new advancement or technological advancents in HIV fields into the module or the training format. And now we are we are expecting with the upcoming youth advocates to be trained on HIV prevention, specifically on advancements such as on PrEP medications and all. And that's all I want to share. And thank you so much for having me, us and all the partners.
Thank you, Dechen. We know that Bhutan has got a very low prevalence of HIV, but still 88% of the infections come from key population. And generally, the sex work is, there is stigma and it's usually quite hidden. But I'm happy to hear that peer-led interventions focus largely on the sexual health rather than just the HIV. And I know Bhutan has got an integrated program with HIV and hepatitis. Thank you for your inputs. We move on to the next speaker, Pooja. Another, she's coordinator of youth-led voices, and I'm told that last year there were 1,800 young people living with HIV of youth-led voices, and they were all 100% virally suppressed. So let us see how the youth-led voices have been able to achieve, and what are the other youth-led high-impact interventions by the organization. Over to you, Pooja.
Thank you so much, sir, again, for giving me second opportunity to speak today. I would like to highlight some key gap in HIV response for young people and offer a few recommendations for strengthening our collaborative efforts. So the HIV burden among the young people remain the unacceptably high. While we have made significant progress, this reminds us that our work is far from over. So one of the major gaps is that many young people continue to delay HIV testing due to self-stigma, fear of disclosure, and discrimination, and also lack of education, sexual reproductive health. As a result, they are a diagnosis late, linked to treatment late, and miss the opportunity to achieve the early viral suppression. To address this, we need to strengthen peer-led social media and digital outreach strategy. Young people spend significant amount of the time in online, making a digital platform a powerful tool, provide accurate information, reduce stigma, promote the HIV prevention, encourage the early testing, and link at young people to the treatment and peer support services. So, the progress of achieved, young people are still being left behind. Continue investment and through the Global Fund essential sustain the expand youth-led HIV services, prevention program, HIV testing, care support, and peer-led initiative. So we have I would like to recommend the moving forward and following suggestions. Continue investment in youth-led, community-led HIV program, as young people are the best place to reach, engaging and support their peers. So strengthening youth leadership by the meaningfully engaging youth people living with HIV in policy making, program design, implementation, monitoring, and evaluation. We also need to have some suggestion to prioritize also mental health services, especially adolescent and young people living with HIV. So stigma reduction and social protection is that young people can access HIV services with the dignity, confidence, and without discrimination. Expand the innovative digital and community-based approach to ensure early identification and the linkage to care for the young people at the Dixie HIV. Ensure sustained domestic and global fund investment so that no interruption and secure the life-saving youth HIV services. So finally, I urge all partners to ensure that no young person is left behind as we work together to end AIDS as a public health threat, investing the young people today, investing in a healthier, stronger, and AIDS-free future. Thank you so much.
Thank you, Pooja. In the interest of time, I don't think I have to really time to give even one-liner after each speaker, which I love to because the carry-home message is that. But since we are running quite late of time, I'll just be introducing speakers after this, and maybe towards the end I can give some concluding remarks. So our next speaker is Jugendra Upadhyay, Project Director at Gujarat AIDS Awareness Prevention Unit. So over to you, Jugendra. Joginder, can you hear us? Hello. So maybe we'll move to the next speaker.
Yes, sir. I think you should move to the
Yeah,
next
yeah.
speaker.
So we have a very powerful speaker now, Joshua Clark, basically, who has been awarded the G Plante Award 2026 last month in Africa. He is from Uganda's Baylor Foundation. And his award was basically for intervention of linking portable X-ray for screening PLHIV in hotspots of eastern Uganda. With this intervention, the TB notification went up by 9 times, and a lot of them were asymptomatic. So we would like to listen directly from Joshua Clark. Over to you, please.
Thank you very much. Good morning, good afternoon, everyone.
Yes, we can hear you.
Thank you for the kind introduction. I'm Clark Joshua, and I work with Baylor Foundation, Uganda. This is how I do look. And in this presentation, we will be sharing with the colleagues on call how we were in position to leverage the resources that we had to ensure that we reached the hotspots. Kindly allow me share my presentation.
Yeah, please go ahead.
So we do know that close to about 40% of TB cases are usually missed in the Ugandan when compared to Uganda versus how many we were diagnosing. We also know that in our country that we had improved facility-based TB screening, but still we continue to miss a sizable portion of TB cases. We also know that in the health, we generate a lot of data from electronic medical records, a lot of data from our electronic case-based surveillance system, a lot of community active case finding logs, but all this data is underutilized. And also in the country, we were in position through Global Fund to acquire 1 mobile van and a portable X-ray. But also because of this, when you looked at the data of the screening coming out of the mobile X-ray versus the symptomatic screening, there was no difference. So this had the problem and the solution at a go. So what we did was to look at this data and merge it, because it had highly granular spatial temporal signals that we could use to build our hotspot engine. So this hotspot engine just looked at, we picked all the data streams that we were getting. We generated, we put it in Power BI and generated in GIS weekly microcatchment populations, where it could direct us to the most at-risk populations or the hotspots. So this, what did it lead to? We would use historical data, we would use data as the events are happening, and then it will calculate for us the proximity, and it would also give us time-weighted targeting so that we can go to the right hotspots at the right time. When you look at the whole process, when we are now at the hotspot where this mobile van is, we were in position to digitalize the whole system from where we are going, the concentration zones, consent and registration, geotagging this residence, where we are, the process of doing the AI scan, because we were using we're using TB technology version 7 and 6, ensuring that because this van had a gene expert machine, we would do testing there and then link them into treatment. So this is just shows the map. This is the eastern part of Uganda in East Africa, and where the vans went. And these are the hotspots. So this is how we were in position to get the different parishes from the different data streams. And in the 109 hotspots that we went, when we look at the ones that had abnormal X-ray, we were in position to diagnose 94 TB cases, of whom 61 were bacteriologically confirmed. While even the ones using the 50% cutoff, we also diagnosed about 15. So meaning that, and that's another study that we are trying to do to look at the cutoff. When we compared this with the symptomatic screen, we see that there was actually 10% yield difference when you compare the two. The other traditional one, we were getting about 1.2, while in this, when we did the targeted hotspot, we got about 10%. Where does this road so far in our Ugandan towards the NTB goals? So we see that in around 2021, 2022, portable X-rays for the country, and this is our study. This is where we, in about September 2024, where we did our study to ensure that we deploy the van to the to the actual hotspots. Currently, because of this, the learnings from this, the government went ahead to, through the National TB Elimination Programme, to procure EPCON AI, and that's now what we are using. It is similar, but a bit better than what we used, because for it has contextual data. So that's what we are using currently. But our study was the first to ensure that it shows us that, look, here we have data, we can use all this data to, with precision, show us where we need to go. Thank you very much. I acknowledge all the colleagues who supported this study, and also the team here for inviting me for this talk. Thank you very much.
Thank you, Clark, just for demonstrating how the technology basically can be used for innovations and for reaching out to people and linking them to care and diagnosing. Thank you very much. My apologies to Takmore. I just missed you. So I would like to now invite Takmore, who leads the group TB people in Estonia. He has been a long-standing community voice for HIV and TB communities. Over to you, Takmore. And my apologies again.
Thank you so much, Session Chair, and your apologies are accepted. I think our program is so much packed such that you often miss some participants and speakers. But nonetheless, thank you so much for the opportunity. Good day, colleagues. My name is Tokmo Mazoroze from TB People Eswatini, which is a country chapter for the global network of people affected by TB, which is TB Global, TB People Global. Thank you for this opportunity to share our intervention, which is focused on community-led prevention and treatment awareness, which is also integrated with demand creation for TB and HIV services, and is grounded in the principles of people-centered care, community system strengthening, and also human rights. I think all of us, we might attest to the fact that TB treatment and diagnostics services are almost available free in most countries. But with that, we often see many people continuing to experience barriers to access to timely and quality TB services. And some of these barriers include the limited TB symptoms, knowledge on TB symptoms and prevention, your TB, HIV-related stigma and discrimination, the weak demand on routine TB screening especially among people living with HIV, and also the issues around community participation, which is limited, and as well as knowledge around TB preventive therapy. So our intervention is trying to address these gaps by ensuring that communities affected are not just passive recipients of services, but active partners in the prevention and treatment support and accountability in the TB response, just in line with the WHO's people-centered approach, that our intervention prioritizes dignity, informed choice, confidentiality, and also equitable access to services, particularly for women, girls, young people, people living with HIV, and other key and vulnerable populations. So the way we implement our interventions is such that it improves community system strengthening through a model that builds the capacity of community actors to deliver the HIV, TB interventions. So within our implementation components, we do training of peer educators, TB survivors, including people living with HIV. And this, I think, builds on their leadership and also lived experience expertise. We also conduct community awareness sessions in places like churches, targeting our congregants, as well as community gatherings, which also include community sporting activities like your community soccer tournaments. And these places offer and provides accessible, cultural appropriate information about TB response. We also do involve social media campaigns whereby we expand access to accurate and TB and HIV information. So our TB survivors are engaged as community champions because they are the people with the lived experiences who knows the journeys that they've traveled through their treatment cascade. And also they help reduce stigma by encouraging health-seeking behavior. And this approach strengthens that trust that you have between communities and health services. And this also promotes meaningful community engagement through the continuum of care. So the impact that we are realizing over the years that we've been doing this is that we've seen measurable improvements in both community engagement and service uptake, such as your people improving on health-seeking behavior, better recognition of the signs and symptoms of TB, improved treatment outcome. As Eswatini, we are doing well on the treatment success rate. So just to cut my presentation short, as most of the things that I was about to say has been alluded to by our powerful presenters we have presented so far, I would like to say the intervention has strongly and strengthened community ownership of the TB response. And the communities are now effectively identifying individuals with symptoms, supporting their referrals, and promoting treatment completion, as well as our advocacy campaigns. They are showing that quality that we have. Then, in addition, I would like to say the intervention also demonstrates that community engagement is a core health system function, not just an add-on activity, as in some cases you might have seen. But I think by investing in community capacity, the leadership and lived experience, we are strengthening border health systems. Just a parting shot, I would like to remind everyone that communities, we are not just beneficiaries of the TB response, but we are equal partners, we are leaders and agents of change. Thank you so much for the opportunity, and over to you, Session Chair.
Thank you, Tokmore.
Dr. Rewari, can I interrupt, please?
Yeah, please.
Can you please invite Jogendra? Again, he's there. I think he could not connect that time. Thank you.
Invite whom?
Jogendra Upadhyay.
Okay.
Thank you.
Okay. So Dr. Jogendra Upadhyay is Project Director at Gujarat AIDS Awareness and Prevention Unit. And Dr. Joginder, please join and share your intervention.
Jogendra, you are muted. Please unmute yourself. So sorry for this interruption, Dr. Rivari. I think you can go back because
it's okay. It's a big challenge having so many speakers. And so move on to the next speaker, basically. Move on to Muhammad Huda, who is Strategic Partnership Officer of Rakyat Peduli Foundation, Indonesia. He would present a community-led intervention in Indonesia. Over to you, Muhammad Huda. Can you hear us? Mr. Muhammad Huda? Okay, maybe we can.
Good night.
Yeah.
Hello.
We can hear you,
Okay.
but not very clear.
Yes.
Please go ahead.
Okay.
We can hear you.
Good night, everyone. My name is Muhammad Tanwirul Huda, and I'm the Strategic Partnership Officer at the Rakyat Peduli Indonesia Foundation. It is an honor to join this important discussion alongside inspiring leaders from across Asia and Africa and Europe. Indonesia remains the country with the second highest tuberculosis or TB burden in the world. Every year, more than 1 million people develop TB. While effective treatment is available, many people affected by TB continue to face another challenge that medicine alone cannot cure: stigma, discrimination, and social isolation. For many people, especially those affected by drug-resistant TB, the greatest challenge is not taking dozens of pills every day. It is losing hope, losing their jobs, facing discrimination, and feeling that no one truly understands their journey. This is why at the Rakyat Indonesia Foundation, we believe that ending TB is not only about medicines, it is about people. Now, what gap in this intervention feeling? One of the major gaps in Indonesia TB response is the limited involvement of TB survivors in decision-making and community-led programs. People affected by TB are often viewed only as beneficiaries rather than as partners who can lead change. To address this gap, Rakyat Indonesia serves as the host organization for TB People Indonesia, a national network TB survivors that currently has chapters in 9 provinces across Indonesia. Our vision is simple but powerful: to ensure that people affected by TB are not only represented but are actively involved in shaping policies, programs, and services that affect their life. Now, how is their intervention implemented? Our approach is centered of meaning community engagement. We strengthened the leadership of TB survivors by providing peer support, implementing community-led monitoring, and developing community paralegal who respond to stigma, discrimination, and barriers to accessing TB service. To that, we have trained two community paralegal and have provided direct assistance to more than 200 people affected by TB through legal support, psychology assistance, treatment navigation, and referral to appropriate service. TB people in Indonesia, survivors become educators, advocates, supporters, and community mobilizer. Help identity people with TB, encourage treatment, adherence, support contact, investigation, reduce stigma, and work alongside health workers and government institutions. And what has been in the impact? Our experience show that community leadership strengthened the overall TB response. More people affected by TB are now able to access support, understand their rights, and participate in improved TB survival. Survivors are currently increasingly recognized as trusted partner in advocacy and community engagement, rather than their simply reception and healthcare service. This growing network has also created strong collaboration between civil society, communities, and government in advancing more people-centered TB response. As international donor funding continues to decline, sustaining community-led response has become increasingly important. We continue to advocate for strongest domestic finance because community engagement should not depend solely on external funding. Government must invest in community because communities are not optional partner. They are an essential part of the Chilean health system. Our experience has taught us one important lesson. When community are trusted, they deliver. When survivors are empowered, they inspire to others. When people are placed at the center, health system become stronger. To move toward the 2030 target, we have only a few years left to end TB and AIDS as public health threat. We cannot achieve this goal by working for community. We must work with community. And much importantly, we must enable the communities to lead. Let us move beyond seeing people affected by TB as patients. Let us recognize them as partner, as leader, as decision maker, because ending TB is not only medical challenge, it is a community movement. Thank you very much.
Thank you. So we move to another intervention which have been proven and which has been partly discussed earlier also by HPPI. So we move on to invite Dr. Bonali Datta, who is head of the respiratory medicine at Medanta. He leads the Medanta's TB-free mission, TB-free India since 2015. So they have got a outreach van with AI computer-aided detection with X-rays. These vans have AI-enabled X-rays, high screen. They screen the high-risk populations, and then those who are found to be positive are linked by HPPI to care facilities. So we'd like to listen from Dr. Bonali Datta now. Over to you. Dr. Datta, are you there?
Yes, sir, she is there. Let's hope. Dr. Bonali, are you there? You need to unmute yourself, Dr. Bonali.
Bonali, okay.
I think there is some technical issue. Is it because Jogendra is also not able to unmute himself? And I do not know about Dr. Datta.
No, ma'am. Jogendra is already a co-host. He will be able to do so. It is there must be some issue on his end.
Okay.
So I will wait. I think we will move on to the next.
Yes, please. Yes, sir.
We don't have Samantha Dinse still not with us.
Yes, no, she is not here.
It's okay. So we have now another intervention from Chub Sok Chemrin, Executive Director of KHANA in Cambodia. He was part of the International HIV/AIDS Alliance earlier, and he was present in Cambodian community-led interventions. Over to you, Chub Sok.
Thank you so much, Doctor, and I'm so pleased to be part of this important session. And I hope you can hear me. Can you hear me?
Yes, loud and clear.
Okay.
Please go ahead. Yeah.
Yeah, I just want to say I would like to support all the previous speaker when we talk about scale the community and key population led high impact HIV and TB intervention. This means that it must be invested. It's not just consult with them, but have to ensure that they part of the planning, they part of the implementation, and importantly, the key population should be in the forefront of all programming. And our experience in Cambodia, as you have been aware, Cambodia is one of the country in the region that recently, officially declare of our achievement of the 395 target for HIV, even though we still have some work to do with TB, but for HIV, because this achievement is not just about the dream. And Kana is one of the local NGO in Cambodia, and we join hands with the government, with the national program since the beginning, and we witness this success. The success of Cambodia is because of very strong partnership from the beginning, in which the government take the full leadership, and set up a strategic plan, and then engage with all stakeholders to come together to discuss of what could be the plan that we need to work together, how the issue should be addressed. So from the beginning, key population, people living with HIV, have been consulted, discussed, but importantly, they also take the lead in providing service delivery, but also closely work alongside with healthcare professionals to observe and to monitor if there is any gap in terms of quality of services. And this allow us, or this have helped us, to bring the services to the people in need. So I would like to say, when the partnership come for the response to HIV and TB, everything is possible. We cannot say we cannot do it. It is impossible. No, if it come together, we can discuss. In the situation where the funding is in a problematic issue, I think that the partnerships still very, very critical, still very, very important, because with the limited resource, and if we try to be divided, this means that we will need to spend more. But when it comes to unify, when it comes to the situation where we can work alongside together, it means that we can share expertise, we can share resources, and we can work together. In our case, in Kana program, most of our partnership is working alongside with the people who experience with the disease. We have people living with HIV, who is one of our partner. But at the same time, we have key population like marriage treatment, transgender population, people who use and inject drug, and sex worker or female entertainment worker in our case, we call it. So these are the people who are delivering services to the community where we work with, where we provide the service to. Under our partnership with community-based organization, in HIV, we have 153 outreach worker and 49 outreach worker for female entertainment worker, and 153 outreach worker for reaching MSM and TG program. And for TB, we have 309 TB survival who engage with the program, with the service delivery. So this means that if we really want to end both TB and HIV for everyone, everywhere, we need to first think about the people who live with the disease, because they the one who have the experience, they the one who know exactly what could be the problem, what could be the need of their community, and they can be a good partner with the government in where the government cannot go to, cannot deliver services. So government and civil society and community are really, really important, that they have to work together, because in somehow some area where it is impossible for the government to do it at nighttime, at the weekend, or at a remote area where the people are hidden, where the people are hiding, because of stigma discrimination, the community, they have the solution to support. So that's why the success of Cambodia, because of this. And I hope our leadership in the program, HIV/AIDS leadership program, Dr. Ovichia, who also in another session, he will talk more about this. But I just would like to say, because of this leadership, because of the government take full ownership and leadership together in partnership with community, with civil society, with people with the disease. That's why the Cambodia success in achieving 95 target. So I would stop now because I have run out of time. So once again, thank to all of you, and we have to say that whenever is impossible, there is a possible way. If the community, if civil society, if people with the disease are part of the problem that we are addressing. So thank you once again. Thanks a lot. Thank you.
Thank you. So, first of all, congratulations to Cambodia for achieving 95, 95, 95. And it is the community basically that made the difference. As you rightly said, community can reach where government cannot reach. It may be an unreached area, it may be after office hours, evening hours. And the relationship community can develop basically is very crucial in reaching out this. Thank you very much for your intervention. And now we move on to go back to now Dr. Barnali Datta. So over to you, Dr. Barnali. We have already introduced you, but just to, again, you are head of the respiratory medicine at Medanta and leading the Medanta's Mission TB Free India. Over to Barnali.
Thank you so much, sir. Sorry, I couldn't connect. I'm still in the hospital, as you can see, and trying to just get a hiatus. So what I would like to say is that Medanta is one of the biggest private hospitals in Delhi NCR. It's a 1,200 bedded big hospital. Now the how we did this was that we had a program where we pioneered. This is way back in 2014. We pioneered mobile vans with a portable chest X-ray. So that's how we started. The goal was to reach people with tuberculosis because the peripheries did not have chest X-ray machines. And so a mobile van would go to the furthest villages, sub-centers, the peripheral health institutes. We worked closely with government. Government would refer patients who were smear negative. These were the days when we just had microscopy and nothing else. And so those who were smear negative and they were just, languishing because we could not confirm the diagnosis, our van went and did chest x-rays and we diagnosed quite a few clinically diagnosed tuberculosis. So that was the first thing that we did. Now, then as we evolved, so it became a big program and we had some very good ambassadors, some key people in the Indian well-known kind of figures who were ambassadors for this. With the help of other corporates, we finally expanded to 6 mobile vans. In the meantime, we got CBNAT, the molecular diagnostics started, and we started with CBNAT machine, then we went on to TrueNAT, which is the WHO recommended molecular diagnostics. And we had all of these machines at our disposal in the van. So we could not only screen the patient with chest X-ray, we could also confirm the diagnosis with the CB-NAT. So that was what was very exceptional. Now, 6 vans, the state of Haryana, where Medanta, the hospital is based, has 22 districts. And in the course of 10 years, in a cyclical manner, we covered all the districts, did chest X-ray and CB-NAT as well. And again, all of this was done in close kind of association with the government TB teams, with the national TB teams. We had a lot of support from them. We worked seamlessly and we recently did a cluster RCT to understand how the ACF will help the notification. And our door-to-door, of course, ACF is door-to-door. You identify the people, you pull them out, get X-ray, get sputum tested, and we increased notification by a little more than 3 times that. So it was a randomized control trial in clusters. So there were clusters which did not have the ACF and those which did. And the ones which did, the notification was significantly higher. So of course, because our role is in the clinical format, we have focused on diagnostics because the government, the National TB Elimination Programme is a vast and very strong program which has penetrated all over. But India being the size it is, the massive population we have, what the government does has to be supported by other stakeholders. Now, another key thing in India is that all corporate hospitals, all corporates, and Medanta being a private hospital, corporate hospital, do give CSR funds, which is corporate social responsibility. And that is a very precious fund. Our entire work over 10 years was funded by Medanta Hospital's CSR fund, and we have had others as well. So one of the lessons from me, and even our research was entirely funded by the CSR fund. So one of the lessons for me was for certain that, of course, global funds are necessary, but I do believe within India we have a lot and we must utilize it. So what we pioneered at that time is now a part of the government program, and every district has ultra portable X-rays, and X-ray is well established by WHO as the screening tool, and then we confirm, of course, with molecular diagnostics and other microbiological tools. So I think intensifying this, getting more corporates to get involved in this, in the fight against TB, I think we will be able to manage a lot. I am a respiratory physician, but also pulmonary health, public health professional, and I think this has been highly satisfying work for me. Thank you very much, sir.
That was great, Bernali, to listen from you. How a public health person turned clinician come outreach, how these activities can, and how can a tertiary center contribute to public health in terms of screening at the grassroots, and that through to a CSR funding. With the declining funds, global fund, donors, everything, I think CSR is another way that could be basically used for not only TB, HIV, and other initiatives also. Thank you for your presentation.
Thank you very much, sir. Thank you.
So we'll move on to the next speaker. I'm not sure Samantha is there. Can you just tell me, Bobby?
No, sir. Dr. Samantha is not yet online.
Can you please ask Jogendra also to come in? I think there was, I think his name is there twice as co-host. He should unmute on the second name. So
Okay.
can you please invite him again once?
Yeah. So, Jogendra Upadhyay, can you hear us?
Jogendra, please unmute yourself. Can you hear? Jogendra is muted. He's still muted. He's not unmuting himself.
So while you may guide him little
Yes,
later on
please,
the phone,
you can,
we can
yes.
move to
Right,
the
please.
next speaker.
Sir, I'm sorry, sir. Sir, Norman is also not online yet. Yeah.
Okay.
No. Yeah. Okay.
So we move on to invite Norman Matting, who leads the TB people. Botswana. He is a multi-drug resistant TB survivor and he has been a strong community voice in Botswana. It will be great to listen to you, Norman, your own experience and the work that you have been doing as a TB survivor and as a peer. Over to you.
Sir, Norman is not online currently. Kindly move on, sir. Sorry.
Yeah, I'm not able to see online people as such. Anyway, we'll invite the next speaker, and the next speaker is Teriro Kudzada, who leads the TB people in Zimbabwe. He will present on Zimbabwe National Network of PLHIV, especially increasing the viral load monitoring and suppression and connecting mining workers to care, a group which is difficult to reach. So over to you, Teriro.
Thank you so much. Am I audible?
Yes, clearly.
Thank you. Welcome. Afternoon, evening, morning, everyone. And it's my pleasure to be part of this conversation. And I would like to recognize CNN's Shobha and team for giving this platform, not forgetting also my leader, Dr. Lucica, and the Stop the Partnership. We thank you for the continued mentorship and giving us some tools to move in a so difficult situation of funding, shrinking space and so forth. But as you always said, we keep the lights on. I'm also wanted to recognize my coordinator for TB people, Olia. Thank you so much, Olia, for also motivating us, mentoring us, and we keep going, and we still keeping the lights on. So today I'm going to give you an overview of an integration program we are doing in Zimbabwe. We are doing in Zimbabwe. So I'm pleased to present a high impact intervention on integrated HIV and TB services. This intervention matters because TB remains the leading cause of death among people living with HIV, and the two epidemics must be addressed together, not separately, which leads to many gaps. TB is both a public health and health system challenge. Zimbabwe's response is now more targeted, community-linked, and data-driven. But disclaimer, I want to put a disclaimer. Integration, but we've realized that not everything can be integrated. And my experience the past month up to today, struggling with the aid writing and so forth as a country, integration, yes, but integration is not for everything. So Zimbabwe is implementing a multi-pronged TB response that combines intensified case finding, preventive therapy, improved diagnostics, community engagement, and stronger data and supply system. So it's a multi-sectorial approach led by the ministry, led by all the civil society that implement TB, including our TB survivors, so and people with HIV and yes. So the country's recent focus includes the Support TB initiative, which is being rolled out nationally, but with priority support in 30 high-burden districts, targeting 184 high-volume facilities. So the questions were high impact intervention in your country. So high impact interventions is scaling up TB prevention, detection, and treatment through the support TB model. This intervention is designed to improve case detection, strengthen case management, prevent new infection, and reinforce local systems such as lab capacity, data management, and supply chains. As I alluded before, it covers the whole country, but we are targeting some more districts and some health centers. What gap is support project fills? Zimbabwe's TB response has faced three major gaps: missed cases with 60% treatment coverage, delayed diagnosis, and incomplete prevention coverage. So the support project is also needed for drug-sensitive and drug-resistant TB services through contact tracing and linkage between communities and facilities. The intervention fills these gaps by bringing services closer to people, expanding molecular testing, improving access to preventive therapy for risk groups such as people with HIV, child conducts, minors, and other vulnerable populations, like it is now minors. But on the preventive therapy, as we move forward, we are worried maybe to be going to have a gap because there's a new policy in the country that all people living with HIV and AIDS are now not repeating after a year, not repeating their TPT, but except for those that will be having maybe AHD or other issues surrounding their treatment. So, but this is the group where our TPT was moving very well, and it was not moving very well in the prisoners, and it is now minors. So how is it implemented? Implementation is happening through a package of integrated activities, as I alluded before. But so it's intensified screening and hybrid conduct investigation. Why we are saying hybrid conduct, the hybrid here, it includes environmental health technicians and community health workers, including our TB survivor, our TB champions in their diversity. Also, it includes shorter TB preventive therapy. It also includes shorter TB preventive therapy arrangements, expanded use of GeneSpect and mobile diagnostic platforms, community engagement, and stronger data systems. So Zimbabwe has also adopted supported tools and guidance for TB preventive therapy, including the preventing TB application and shorter arrangements such as 3HP and 3RH to improve uptake and completion. Also, currently, we are piloting the near point of care equipment. But we are still piloting, and we hope that once it's approved and so forth, it will help us a lot. Because when you look at it, is now minors, they are in hard to reach areas, regardless the fact that we've got 12 mobile vans, huge mobile vans. But again, when you get there, you find out that you might be stuck. The huge mobile van cannot maneuver in the areas where it is now minus one. So we are so excited that this the near point of care will help us also to reach more, and also we can even use even small cars like unlike only the huge mobile vans, as was alluded on the picture there. I was just trying to demonstrate how we work. It's like it's a combination of the van, the community health workers, and the people. And remember, the community health workers are the frontliners. They go a day before mobilizing people, giving in information, and also to prepare the clinical people when they come. So the approach is both based, it's community based and facility based. So hello?
Hello, yeah.
Can you hear me?
Yes, Tariro, it's a time issue actually, so it will be great if you can quickly wrap
It's
up.
okay, it's okay.
Already
It's
4
okay.
minutes.
It's okay. So the approach is also important for the approach. Why it matters, the interventions matter, because TB control depends on early detection, prevention, or progression of disease, completion of treatment. And this approach is also important for health equity because it targets high risk and hard to reach groups that often face greater barriers to care. Thank you.
Thank you, Tariro, for highlighting how a community-led intervention can be really useful in reaching out to people who are not reached by conventional government systems. Thank you. Do we have Jogendra Upadhyay or we move to the next?
We move to the next, sir.
Or move
Okay.
to the next one, yes.
Okay, so I invite the last speaker, Dr. Rakesh. Dr. Rakesh is a noted TB elimination consultant. He is director of Foundation for Health System Strengthening. He also served as a deputy director in International Union till recently, and he has shown that TB can be eliminated even in a high-burden country. So we'd like to listen to you from you, Dr. Rakesh.
I'm just checking whether my screen is visible.
Yeah, your screen is visible. No, it's full screen.
Yeah,
Please go ahead. Yeah.
Yes, hi. Hi all. So I'll be just telling a brief story about how a people's movement against tuberculosis has made Lakshadweep India's first TB-free geography. For people who they don't know about Lakshadweep, it's an archipelago in the southwestern part of India. 10 small islands spread across the Arabian Sea, separated by the vast, huge oceans there. And geography was once considered the biggest barrier to TB elimination there. During the monsoon season, for the almost 6 months in a year, the island is entirely isolated. They cannot even travel from one island to another island. And the administration there, they have, based on a call from the government of India, they framed a strategy document for TB elimination mission. And the strategy document was formed based on lots of conversations, sitting on the beach side with all the local representatives, community members, and all. And it's a highly customized version of what is possible there. And it's entirely different from the mainland TB guidance documents. And this has been released by the entire bureaucrats and the elected representatives in a big function attended by the entire population of that islands. And this is the picture, the landmark picture where all the community volunteers from 10 different islands, they pledged to make their islands TB free. This day, TB stopped belonging to the health department alone. And the intense trainings and everything has happened. And another important major milestone that happened there was the formation of TB elimination task forces in each of the 10 islands. And this task force consists of committed people who are, some of them are officials, but most of them are volunteers, responsible people, religious leaders, local government representatives, youth clubs, and the women self-help group members. And they regularly met on a monthly basis to review the TB situation of their islands, plan, and troubleshoot any of the issues. They even help in mobilizing resources in terms of community volunteers for door-to-door screening. They went to the patient's house for providing treatment support. And the biggest problem there was basically the sputum sample. It takes weeks to cross the islands and reach a place where TB testing could be done. The biggest intervention that happened from the side of health system was basically a decentralized molecular testing. Each of the 10 islands were equipped with a point of care rapid molecular test. And this decentralization ensured that every island could perform the TB test with its own hands. The major intervention was the community volunteers, the women, the empowered women there, a highly literate society where they could take their own decisions. And the community volunteers, they went from house to house for 7 consecutive years screening for TB. So this is basically the biggest intervention that happened there. And they ensured that all the presumptive TB are tested and put on treatment. I'm not going into details, but I just want to say that 7 consecutive years, the TB screening happened there with the best available technology of that particular time, what is possible, what is feasible there. And almost these 7 years, they touched almost 3/4 of the entire island census population per se. And year on year, the number of TB diagnosed came down. And finally, Government of India, WHO India, and ICMR certified Lakshadweep as India's first TB-free geography. This is a technical picture, but I just want to say that compared to the current incidence of TB in India of 200 per 100,000, Lakshadweep's TB is much less than 20 per 100,000. And that came dramatically from almost 70% decline over the last 7 years there. Yes, the sun of TB-free India rose in the West. The key takeaways from these presentations are bringing surveys closer to people. That is something which really is essentially important. And diseases are eliminated when communities become the owners. The simple interventions delivered consistently that really work. We don't need complex interventions for achieving elimination. And TB elimination is achievable. I have narrated this entire human story behind India's first TB-free geography in my upcoming memoir, Echoes from the Atoll, Inside India's TB-free Islands. I'll stop here. Thank you so much.
That was great. Thank you, Rakesh, for sharing this. And the key words like decentralization, community engagement, and consistency over the years basically has been the key, as you said. And rightly said, it is achievable. And India, I think, will be the first country to achieve it at the earliest, ahead of the other countries. Thank you. So as we move towards the close of this session, I would like to thank you, all of our incredible speakers who were spanning across Asia, Pacific, African regions. We heard powerful evidence-based testimonies from over 17 frontline workers and clinical experts, right from primary healthcare to community to a tertiary care center. And they showed how community-led interventions are actively filling the critical gaps and bridging the gaps, how they are being successfully deployed, and the impact they are making. So as we conclude this session, and we are short of time, but we have 3 definite takeaways that I must say, and our effort should be guided over next 50 months on these 3. Communities are the infrastructure that we need to adequately take into consideration. They are not the targets. Integration is non-negotiable. This has come across HIV and TB and now hepatitis and other areas. The power of youth and innovations needs to be adequately utilized. So to echo the campaign slogan, we can do it better, business as usual will fail. And it is important that we hold ourselves accountable, scale up these grassroots models, learn cross-learning from what has worked and what has worked elsewhere and how it can be implemented in our situation. So thank you to the organizers. Thank you to the speakers for charting the path forward. Let us carry this momentum to the next session, session 4, as we discuss bridging the deadly divide between knowledge. We have the knowledge, we have actions. How can we fast track that? So we'll have people from WHO, Global Fund and ministries. So I hand back to the organizers and thank you once again.
Thank you, Dr. Rivari, for conducting such a marathon session in your own special way. And this is just one last time I'm calling out to Jogendra Upadhyay if he's there to present his case. Jogendra, can you unmute yourself now? I'll just wait for a second if you can do that. Otherwise, we move on. Jogendra, can you hear me? Okay, I think there is some problem at his end. So now I invite Dr. Sachdeva, Dr. Kuldeep Singh Sachdeva to chair the next session. Dr. Sachdeva is former head of Government of India's National TB Elimination Programme and National AIDS Control Organization. He is also former Southeast Asia Director of International Union Against Tuberculosis and Lung Disease and is currently President CMO at Molbio. Over to you, Dr. Sachdeva.
Yeah, thank you, Shobha, Bobby, the organizers of this meeting, and my colleagues who presented earlier, Dr. Rivari and others. Yeah. So the session 4 is on bridging the divide between what we know works and what we do to end TB and AIDS by 2030. So we have a line of speakers from governments, donor agencies, and other people who have worked on both TB and HIV for quite a long time. And we all know that most gaps, we just heard 17 presentations from the community people on what works and how they need to be scaled up and how they can fill some of the gaps that exist between what we know and what we actually do. Most of the gaps addressed were related to the gaps in the cascade of care. So most presentations were related to sort of case finding or diagnostics. How do we find more cases? How do we sort of then take them to link them to treatment and ensure that they are adherent to treatment? And then for HIV, ensure viral suppression. For TB, ensure cure. There was a lot of talk about sustainability in financing, but very no solutions. Community members actually desired that they cannot do anything without a sustainable financing, and maybe most of these questions will go to the speakers who will be presenting or speaking in this session. So when we talk of sustainable financing, 2-3 thoughts come to mind. What suffers most when you have less financing, or what is a common topic these days is that with most donors having a reduced potential to finance some of the interventions, and also governments, some of the governments filling in that gap, but still there is a gap. So what will suffer most when the financing goes down? And the obvious answer which comes to my mind is the prevention is the one element which will suffer the most. And we did see some examples of prevention presented today, prevention efforts presented today. The next maybe case finding or diagnostics or testing is likely to suffer, and maybe to some extent less human resources, less monitoring, less oversight, governance, etc. And Dr. Rivari talked about integration. So how do we actually now ensure efficiencies is one way of doing efficiencies in integrating various programs, getting them together, look at efficiencies in other areas, which is your procurement, supply chain management, other logistics. And what impacts the program most becomes very important. Then also identify which are the priority interventions which can lead to sort of more public health impact. So prioritize more money there and look at efficiency in the other areas. Accelerate or speed up rollout of interventions which are scientifically well documented. And within the prevention, maybe more money on viral load testing, more money on finding TB case finding, so more efforts on active case finding them cases early, and also on a person-centered, right-based cares, and ensuring accountability mechanism amongst all stakeholders, including governments, civil society, the communities and other stakeholders, and each acting as a check on the other stakeholder to ensure accountability and also be accountable themselves. So with this, I'll start introducing our speakers for this session. The first speaker is Dr. Pauline Chan, and we all know her. She's currently based out of WHO CRO. So Pauline Chan is unit head of hepatitis, HIV, STI, EMT-City, TB, Department of Health Promotion, Disease Prevention and Control at WHO Southeast Asia. Over to you, Pauline, for your thoughts and how do we move ahead in these uncertain times?
If I may, I will share my screen. Do you see my screen?
Very well, Pauline.
Thank you very much. And very nice to see you again, Dr. Sachdeva. And also, I have to say that I've been on this webinar the whole day together with the participants, and it has been illuminating and inspiring and difficult. I have to say these times have been very, very difficult. And I think we all have to acknowledge it. And whatever it is, to give ourselves a pat in the back of trying to survive and thrive despite these challenges as well. So I'm going to give you an epidemic overview of the Southeast Asia region, where many of the participants are, because it's important to contextualize what does it mean by integration, or in other words, convergence, or linkages, or optimization, or leveraging. Because at the end, whether you talk about HIV, malaria, or TB, it's the same pot of funding that goes into overall health. And it's really about trying to understand what does sustainable financing for health actually mean. I'll put on my next slide. So if you look at taking the WHO Southeast Asia regional burden, that is 10 countries after May 25, the Southeast Asia region consists of 14% of hepatitis B and C of the global burden. There's quite substantial infections and death. We have very poor data still on hepatitis B, and we know there are many hundreds of thousands of pregnant women are infected with hepatitis B, which means transmission to the next generation of young still remains a risk and is happening every day. The overall birth dose for hepatitis B vaccination is still a mere 58%. Theoretically, it should be more than 90%. In HIV, in this region, we have 3.5 million in the 10 countries, including children living with HIV. There is an overall 26,000 pregnant women with HIV, 70,000 children living with HIV. And incidentally, even when HIV reporting has been around for 3 decades, in this region, only 3 countries report PMTCT coverage in 2024, and with a big range between 50-something% to almost 100%, 90-something%. In STIs, it's substantial. We have very poor surveillance in STIs. We know that there's drug resistance in STIs and drug resistance gonorrhea too. There's 60 million new infections of the curable. Syphilis is a problem, including congenital syphilis. We are mere 3.5 years from the SDGs, and we're still battling about the 8,000 congenital syphilis in infants. In TB, we are doing not too badly, actually. The Seattle region is very high in TB cases, and we consist of almost 40% of the global TB deaths and cases. But every TB household has about half of them have catastrophic expenses. So it is expensive to society, expensive to individuals, and expensive to families. But the good news is that actually in the Southeast Asia region, TB case notification is good, and the treatment successes have been good. So we know that once people are detected earlier, success for treatment is good. We also, in the last several years actually, had a lot of success in the concept of integrated elimination or multi-disease elimination. The triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B has been really a flagship for this region. There's a lot of progress. We have 3 countries that have some form of elimination of mother-to-child transmission for HIV and syphilis. And last year, for the first time, Maldives achieved the triple elimination of mother-to-child transmission in October last year, and is the first country globally to have ever done so. This is a feather in the cap, not just for the country, but for the region and for the communities and partners and donors that work towards it. But what it also says to us is that elimination is feasible, is doable, And what it means is that we need to integrate and have strong political commitment and leadership, as well as a surveillance for it. Now, we have had a long history of elimination of communicable disease in the last decade. Maldives is being one of them for multi-disease elimination approaches. And the call to action for elimination for all the different conditions from HIV to STIs to hepatitis, including for TB, is that it's really about combining the existing interventions at scale and making sure that innovations, quality assured diagnostics, multiplex diagnostics, self-testing, self-care, as one of the previous colleagues talked about, and access to pre-exposure prophylaxis, the oral and the injectable one, and the new generic injectables, which will just be $40 a year. And that is going to be likely a game changer for new infections. And about ending TB. This year, the World Health Assembly talked about developing the post-2030 TB strategy. We already know what is working. We know about everything from case finding to digital health to AI-assisted X-rays and screening. We know that community-based treatment and screening exist. But we have still the persistent multi-sectoral challenges. The cascade of care, as you said, Dr. Shakdeva, delayed diagnosis, incomplete case detections, multi-drug resistance TB, comorbidities and drivers like undernutrition, diabetes, poverty, catastrophic household expenses. These are not just TB, this is a UHC agenda, and we have to work on the UHC agenda together with all partners to work on this. What we know is that we can accelerate, we can improve, we can prevent, and we can embed and converge and to work across all the different health programs right now. So how do we adapt? We always say do more with less or do more or do better, but really it's about doing differently. And if we do differently in partnership, converge, break the silos, I believe we can get there. Thank you.
Thank you, Pauline. I think your take-home message is very good. Do things differently, and it's possible, still possible to demonstrate elimination. You demonstrated triple elimination in Maldives. Rakesh referred to elimination of TB in Lakshadweep. So things are still possible even in these challenging circumstances. Thank you, Pauline, for those the presentation. I'll move to the next speaker, which is Anna Malson. Anna is Manager Thematic Cluster on Key Populations, Community Engagement and Responses at the Global Fund. Anna, over to you.
Thank you. Thank you, Dr. Shakdeva. It's a pleasure to be here and always a pleasure to follow my old friend, Pauline. And I also have been joined, not as long as Pauline today, but it's been really fascinating to listen to all of the stories coming out today and the reality that we're working in. So a big thank you to the organisers and the community partners for convening this important discussion. I think this session really asks us a critical question. How do we bridge the divide between what we know that works and what do we do in practice to end AIDS and TB by 2030? And that framing is clear. We have the evidence base, the science base, and the community-led tools, but we need to scale up and identify sustained financing for person-centered, rights-based, and community-led solutions with urgency and accountability. We will not end AIDS or TB unless the people most affected are at the center of the response as leaders, implementers, advocates, and accountability partners. First, strong community systems are essential to closing that implementation gap. Communities often know who first is being missed and who is falling out of care, who is afraid to seek services, and where stigma, poverty, violence, and discrimination are creating barriers. Community-led and community-based organizations support outreach, prevention, testing, linkage to treatment, adherence, retention, treatment literacy, and action to reduce human rights and gender-related barriers. community-led monitoring and advocacy, such a critical role and so diverse in what they do. The UNAIDS Global AIDS Strategy calls for community-led responses to be fully recognised, empowered, resourced and integrated as part of a sustainable HIV response. The Stop TB Partnership similarly emphasises meaningful engagement of TB-affected communities in planning, implementation, monitoring, review, advocacy and governance. And here at the Global Fund, as part of our Grant Cycle 8, community systems and financing is a key shift that we want to see. We want to see greater investments in community systems despite the challenging times that we are in. Second, we must focus intentionally on key and vulnerable populations. The gap between what works and what is implemented is often widest for the people living with HIV, affected by TB, HIV key populations, people in prisons and closed settings, migrants, adolescents and young people, women and girls, people with disabilities, and people affected by poverty or displacement. For many people, that access is not only about whether a service exists, it's about whether that service is safe, confidential, affordable, respectful, and reachable. Thirdly, human rights and gender equality are central to health outcomes. Stigma, discrimination, gender-based violence, legal barriers, and breaches of confidentiality all reduce the effectiveness of HIV and TB services. In TB, community rights and gender assessments have documented barriers and informed actions to address them. Evidence from the Global Fund's own Breaking Down Barriers initiative demonstrated that sustained investment in reducing human rights-related barriers helps to increase access to and uptake of health services among affected communities, contributing to improved health outcomes and a more equitable health system. Human rights and gender responses are therefore not optional add-ons, they are part of quality programming. Fourthly, integration should be practical and people-centered. People do not experience HIV, TB, sexual and reproductive health, mental health, violence, poverty, and stigma in separate boxes. Services should be organised around people's lives using trusted, accessible entry points such as primary healthcare, community sites, antenatal care, harm reduction services, prisons, drop-in centres, and differentiated service delivery platforms. So what must change now? We need that sustainable financing for community-led organisations. We need community engagement in planning, budgeting, implementation and review of national programmes. We need scaled-up community-led monitoring. We need stronger human rights and gender programming and the data that helps identify who is being missed. As we approach 2030, the question is not whether we know what works, we already do. The question is whether we can act with scale, focus, and partnership required. If we put people and communities at the centre, we can move from evidence to equity, from access to dignity, and from knowing what works to doing what works. Thank you.
Thank you, Anna. Rightly concluded, access to dignity. I think the Global Fund is rightly placed to advocate for this area of community-led interventions, and the HIV program has already articulated about 30, 80, 60 framework. Maybe we should see something similar in TB and malaria. Global Fund is can be the right enabler to take this forward. Thank you, Anna. Next, I move to next speaker, which is Bahati Hole. She's from the United Communities Delegation. Over to you, Bahati.
Thank you so much for giving me this opportunity. Please confirm that you can hear me.
Very well.
Thank you so much. Good morning, good afternoon, and good evening from different parts of the world. As I have been introduced, my name is Bahati Haule, and I speak today as a member of UNAIDS Communities Delegation, as someone representing communities of people living with HIV. And as from within UNAIDS, we stand at a very critical point where we just recently celebrated 20 years since the governments of France, UK, Norway, Brazil, and Chile, who in 2006 made UNAIDS to increase access to innovations which were not available for majority of people in low and middle income countries. And as we meet today to discuss on what needs to change or what needs to be done for the next 54 months, I echo the words of the previous speaker, whereby we must be honest that the greatest challenge is not that we do not know what works. The challenge is that millions of people still cannot access what we already know works. We are at a point in time where we have the science, we have the medicine, we have the diagnostics, and we even have the evidence. Yet too many people are still diagnosed late. People are dying from preventable illnesses and still falling out of care. And there is a deadly divide between innovation and access, because as community partners and community policymakers in across our different interventions and countries, we know and have the evidence that community-led intervention do actually improve testing, linkage, adherence, retention, and even accountability. And we know innovations such as long-acting can actually transform whether it's that prevention or treatment. And currently where we're at a space where we know that issues like advanced HIV disease can be diagnosed and managed early, and of course that TB is curable and preventable. Yet we still have people in our community that still experience gaps and challenges of stockouts, diagnostic gaps, delayed treatment, initiation, stigma, criminalization, but of course with the current phase of shrinking funding for community-led services. And the result is that people die not because solutions do not exist, but because solutions do not reach them when they need them and in time. And we all have talked since, I think, a few hours ago, and we have all, I think, agreed and understand that communities are not only beneficiaries of the response, but they're also implementers and decision makers within this response. And across a number of our high burden regions and countries, we do see how community networks are finding people who have fallen out of care, supporting adherence, tracing the treatment interruption, but also identifying cases, monitoring stalkers, but also connecting people back to services. And when these communities are funded, services reach those who are most often left behind. And at most times when these communities are excluded, that's when we see the gaps widen. And we are at the current point where we see the global AIDS, the new global AIDS strategy that recognizes how community leadership is central at ending AIDS by 2030. Yet we have heard and seen today how community organizations continue to receive only a fraction of the resources needed to sustain their work. And if we are serious in ending AIDS and TB by 2030, we should have priorities that look at one, accelerating access to this proven innovation, all the way from diagnostics to treatment to prevention, and particularly for the most vulnerable population. So when you speak about children, adolescents, women, and key population, but also investing directly in community-led responses, making sure that health systems are sustainable and that they also involve sustainable community systems. And thirdly is strengthening accountability and sustainability. So every stockout, every treatment interruption, every delayed diagnosis represent a failure of implementation, not a failure to science or of science. So the question that we have today is not what works, but the question is, why are we not delivering what works to everyone who needs it? So as communities across our different platforms today, and as a member representing communities within UNAIDS, we are not asking for new commitments or for new promises. We are in need of action on those commitments that have already been done for a great number of years. Because in order to bridge the divide between knowledge and implementation, it's not only a technical challenge or even a funding challenge, at times it's even a moral imperative. And that if we truly put people at the center, that if we fund communities but also scale proven solution equitably, ending AIDS and TB by 2030 remains within our reach. And I would like to wrap up as my time is up, that people are not dying because we lack solution, but people are dying because solutions are not reaching them fast enough, fairly enough, but also consistently enough. Thank you so much, and back to the moderator.
Yeah, thank you, Bharati. Your points are well received and also heard by other speakers present currently in the room. And as you heard our previous speaker, Anna, she already confirmed that Global Fund is looking at the community-led and community-owned responses to that. So thanks for raising and bringing community perspective to light. We'll move on to our next speaker, which is Dr. Tara Singh Bam. Dr. Tara Singh Bam is a former Asia Pacific Director of International Union Against TB and Lung Disease. Currently, he leads as Board Director of Asia Pacific Cities Alliance for Health and Development. And he's also the Asia Pacific Director of Tobacco Control at the Vital Strategies. I invite Dr. Tara Singh Bam to come and share his views and on this. Yeah, Dr. Bam, please.
Thank you very much. Can you hear me?
Very well.
Yes, thank you. Let me share my slides. I have few slides to prepare. I hope you can see it. Thank you again. So, yes, all the speakers highlighted very key points, how to really eliminate tuberculosis and also work together with the HIV, TB, HIV program. So, based on my experience working in public health, especially on TB and tobacco control, so I'm going to share some of my experience and learning from the field. Why are we still not on track to end TB despite the decades of scaling of TB services? So as we know, that I think all we have recognized that there is significant progress in TB control programs, and the millions of lives saved and significance, the achievements in TB treatments outcome and also in TB diagnosis. But there is still a fundamental question still there. Why is TB still one of the world's leading infectious, the killer disease? So for this, I have, try to summarize some of the point is what we see now in many countries, including my country in Nepal. So we see the current success of TB control is a success of, leading to TB elimination, but actually it's not. So that's my own observation. So what the current program that is focusing more on diagnosis and treatments, of course, both of them, they are really needed to save lives, but they are not enough. So what we need to do also, to really to include some of the additional variables in our TB control programs measurements. That is also including the prevent TB, reducing the risk factors, and stop new infection. With this, I'm trying to summarize some of the the key the factors why we are really falling behind. So some of the points that I would like to highlight is there still in many countries, in many settings, so haven't really dig out the root cause of TB or the risk factor of the tuberculosis. So our screening strategy still remain into is limited, and universal health coverage is not complete. The majority of the TB patients in many of the countries are the out of the US program. There are many funding limitations, but the domestic funding still hasn't been actually tapped by the many TB control or HIV control programs. The health, our system is more on the reactive rather than the preventive. There are many social and economic barriers that we observe, also discussed in the previous, the session as well. So there are, in many countries, if you look at the target, the progress, that is not quite enough. It's like a very traditional and conventional approach still we are applying in many of the settings. So one of the things that is still Dr. Pauline from WHO, she mentioned local government's engagement is one of the key to success for any public health program in many settings, in many countries. Even including in my country, in Nepal, it hasn't been effectively utilized for TB control program. Therefore, we really need to have a local leaderships and local political wills and integrate the TB control program in the local development agenda is another key issue that we need to also discuss further. So the key risk factor, when I talk about the prevention, there is a WHO reports, 2025, the TB reports highlights the key 5 risk factors, including the undernutrition, diabetes, alcohol use, smoking, and HIV infection. The million of the TB cases because of these the risk factors. And for example, like in our setting, India or Indonesia or Bangladesh or Pakistan or Nepal, the smoking or the undernutrition, these are key prime risk factors. So I think the TB control programs or the elimination program, whatever we call, really need to also highlight the prevention program as well. So as I mentioned earlier, the current TB program still they start the services from the person who gets sick. And from that point, and start diagnosing and treating and repeat the same thing over and over. So I think that now is a time to really shift from the treatment to prevention or TB elimination. That should include the addressing the the risk factors, as I just mentioned earlier, the 5 key risk factors, and we should really have like an active case finding or screening, mass screening, diagnosis and treatments, and prevent the recurrence. Some of the elements is happening in some of the setting in some of the countries, but it's not happening in many of the countries. If we are really shifting our focus from the control to elimination, we really need to pay our attention in these elements as well. So Dr. Sachdeva already they pointed out some of the things is funding. As I mentioned earlier, all the TB program, of course, they require the fundings, and most of the TB programs they are rely on the global fund or the international funding or donor funding, and there is very minimum local fundings. But what I'm trying to say, to highlight here is there is local fundings available, but we need to really find the ways. So, like for example, health taxes on tobacco, alcohol, sugary drinks, and these are some opportunities and easily. It's a low-hanging to actually in terms of the funding. Or if the governments increase the tax on those, and of course the immediate impact is to reduce the risk factors, and also it will also help to generate the revenue. That money can be used for the TB elimination program or primary healthcare or universal healthcare services. So this type of model that we have just that we are in process discussing with the Ministry of Health in Nepal and some of the other countries as well. So Ministry of Health in Nepal has established the National Health Fund. So hopefully some of the fund that will be used for the primary healthcare or TB elimination and USC. So just to conclude some point here, we really need to have the local leaderships and the local political will and identify the domestic resources, especially raising the tax on tobacco and also the alcohol and sugary drinks, and that establishing the special fund using the money for the programs as well. So with this, actually, I would like to conclude here because it's really important. We need to find the ways to really eliminate the tuberculosis, the working together and engaging the multi-sectors in this whole initiatives. Over to you, Dr. Sachdeva. Thank you.
Thanks, Dr. Tara. Your message on TB prevention, focusing on TB prevention, the risk factors for TB, and also raising local funding is well received. You also referred to involvement of local governments, political people. I want to let participants know that Dr. Tara founded Asia Pacific Alliance of Local Governments, which is led by mayors and members of parliament across 100+ cities, which focus on TB, tobacco control, non-communicable diseases, antimicrobial resistance. So some of this can be replicated or tried out by some other countries. Thank you, Dr. Tara. I'll move on to the next speaker, which is Hasina Subedar. She's a senior technical Advisor, National Department of Health, South Africa. She has led the HIV prevention efforts in Ministry of Health, South Africa, and is instrumental in rollout of pre-exposure prophylaxis through and lenacapavir in South Africa. Over to you, Dr. Hasina.
Good afternoon and good morning and good evening. Thank you very much for inviting me to share our experience from South Africa. I'm going to share my screen very quickly. Apologies, it's taking up my time. So just to answer the question, looking at what we know works and what we should be doing, sorry, my slides are not moving. What's quite important is just to say that we do know that prevention and treatment saves lives. We do know that we need to integrate and integrate into our existing services, and through integration we can improve access. It's important that we always take communities along with us, making sure that we have people that can relate to our communities through peer educators, making sure our civil society and affected communities are brought on board to create an improved demand and support for services. But most important is also, as we move along, we need to make sure that we use data to identify what we're doing well, what we're not doing well, and how we actually improve our performance. Having said all of that, we also, looking at what must we do to close this gap. And in South Africa, we have strong policies and we have tools that we've been using, that we've used consistently across the district. But is that sufficient? Also, the other thing that we do, we know that we need to make sure that prevention needs to be not just an adjunct to HIV treatment, but it's an essential part of our programs. Expanding HIV testing and prevention and linking people to services is critical, and also protecting and making sure that we not only provide these services, but we need to make sure that the ability to continue and the quality of services that we provide are paramount. Also, we need to look at where is it that we really need to focus our attention. We do know that there are populations that are in dire need for these services. We have high HIV incidence, and also making sure that we establish partnerships with those in those areas. So looking at South Africa, we rapidly scaled up oral PrEP in the country. We have currently 2.2 million individuals that have taken up oral PrEP, and we've integrated oral PrEP into our public primary healthcare facilities. And, we've seen rapid growth. But despite that, what we do know is that oral PrEP has not been giving us the yield that we want in terms of rapidly reducing HIV infections. We've also used, when we scaled up oral PrEP, we also used a precision-based approach where we looked at how do we reach our populations, who are the populations that are most in need, identifying those populations that are at HIV negative, that will benefit from these interventions. But within those populations, we do know that there are people that have greater need for HIV prevention services. And we need to look at how do we make sure that we create demand for those individuals. And I think this is something that we, as we move along, we've tried really hard to try and reach those populations. And I want to move on to looking at where do we want to go to? And our modeling data and our modeling assumptions have been that lenacapavir, which is the 6-monthly injectable, can change the HIV epidemic trajectory. And we do know that it could also speed up the reduction of HIV infections. But having said that, we need to make sure that we don't just provide it in small numbers, but we need to go into scale. And our modelers have indicated that if we need to have impact, we need to reach at least 1.2 million people per year. We need to invest money. And we do know that lenacapavir, once we have generic formulations, to be able to then reach more people using the $40 per person per year. Also making sure that we target those individuals that need it most. And if I'm going to move to the next one, where we actually just look at lenacapavir can fill a gap, especially looking at reaching those in high burden areas. And South Africa is one of those countries where we have a very, very high HIV infection rate. We do know that oral PrEP does not work for everyone, but it has created the platform on which we can offer the long-acting products. And I think one of the advantages of the long-acting product is that even though we require people to come into a health facility and it is medicalized, given that it's an injection, it does provide the opportunity to offer something that people only need to visit a facility every 6 months. So it does address the gap of making sure that we have improved choice, where people don't want daily pills and they have a better option to take, which is a 6-monthly injection. Also, it could fit into people's lives. It also will help us reach priority populations. And if you look at the priority populations, looking at female sex workers, gay and bisexual men, pregnant and breastfeeding, adolescent girls and young women, transgender, and people who inject drugs. These are populations that would greatly benefit from lenacapavir. And South Africa has started implementing lenacapavir on the 5th of June. And as I speak right now, we've had over 15,000 people in a very short period of time that have accessed lenacapavir. And there are plans afoot to, once we have generics available, to make it more widely available. Thank you very much.
Thank you, Dr. Sina. Appreciate your program on lenacapavir and your message that if you have to realize the impact of it, take it to scale and treat prevention on the same footing as you treat treatment, which is a very important message to the leadership per se, who sort of in times of reduced funding, they try to focus mainly on treatment per se. So well received. Thank you, Dr. Asina. Our next speaker is Dr. Auk Vichia, who's our director at National Center for HIV/AIDS, Dermatology, STI at Ministry of Health, Cambodia. First, congratulations on achieving 95, 95, 95 landmark, and very eager to listen to you. Over to you, Dr.
Yeah, very good morning, good afternoon, ladies and gentlemen. I'm very pleased to be with you all day today and share experience from Cambodia regarding the HIV response. Cambodia's journey to achieve the 95 target in 2095 demonstrate that ending AIDS is not only the technical matter, but fundamentally a matter of strong leadership commitment, translating evidence-based innovation into action. Today, Cambodia has achieved remarkable like 95, 100%, 98%. At the heart of this success lies very strong and sustained political commitment. For decades, Cambodia leadership through the Royal Government Cambodia, National AIDS Authority, and Ministry of Health, healthcare at all levels, strong engagement in community-led response, and early adoption of various prevention approaches have placed HIV firmly on the political, not on our national agenda. This commitment has ensured clear policy, coordinated multi-sectoral and health sector action, engagement with development partners, like UNAIDS, WHO, US government, and also our donor Global Fund and sustainability investment, even in the time of competing priority. Importantly, political leadership has gone beyond the declaration. It has been translated into the practical action, from supporting community-led response to ensuring that key population remain priority in our national strategy and policy. This creates an environment where we know the work is actually implemented at scale. Building in this foundation, Cambodia priority people-centered and community-led approach through the community-led service for HIV prevention, testing, care, and support, helping to ensure quality, reduce barrier, strengthening accountability. They ensure that services are not only available, but also accessible, acceptable, and trusted. Cambodia has advanced combination of HIV prevention and innovation, recognize that no single intervention is sufficient to prevent HIV. The expression of differentiated HIV testing at scale of PrEP and also new modality like we have implement cabotegravir and integration HIV service and helping to close prevention gap, particularly among key population. At the same time, the country has institutionalized data-driven decision. We use triangle routine program data, IBBS, and community-led monitoring data to identify gap and adjust the response, ensure that the program and service remain responsive and targeted. However, Cambodia experience also remind us we have gap between we know and what we do still persists. Despite the strong progress, new infection concentrate still among the key population and young KP. Structural barriers such as stigma, discrimination, and social inequality continue to limit access to services for those most at risk. Bridging this divided require us to double down every factor that have driven the success. It means that sustaining high-level political leadership, especially in the context of declining external funding. It means that increasing domestic financial gradually, particularly in the prevention and community-led response. It means that accelerating scaling up of innovation and ensuring they reach those who need the most. And critically, it means ensuring the community remain the center of our response. Cambodia is now entering the new phase, one of greater country ownership and sustainability. This transition underscores a key lesson: achieving 95-95 is not the end point. It is a milestone that we must sustain, deepen, and make more equitable. In conclusion, Cambodia experience saw the bridging the gap between what we know and what we do is possible. And when its strong political will aligned with system, innovation, adequate financing, and empowering the community. If we want to end it, we must ensure that evidence does not remain on the paper, but translate into action at scale and without delay. Thank you. And we also would like to thank our donor like Global Fund and US government and many partners in Cambodia.
Thanks,
Thank you.
thanks, Dr. Hook. Well, appreciate your achievements and more. What we appreciate more is that despite achieving 95-95, you are still identifying gaps between what you don't do currently and what can be done. So your focus on rising new infections, stigma, discrimination is very good and much appreciated. And also on transitioning to domestic funding, a lesson for other countries to follow. Thank you. I'll move to the next speaker, Dr. Reshu Agrawal, who's a technical expert for HIV, hepatitis, EMTCT at the World Health Organization India. Over to you, Reshu.
Am I audible and my screen is visible? Could you confirm, sir?
Yeah, your screen is visible and you can be a bit louder.
Sure. So Dr. Pollen from CRO has already set the context, and when we talk about these infections, we do include hepatitis as well as STIs with HIV and TB. So I think everyone was talking about the paradox that we really have the tools, but I think question now is like, how do we really make the implementation fast enough so that we are able to reach as many people who need it, and we are able to achieve the 2030 targets. So just like, just going forward from where Dr. Pollen left, I tried to unpack, like, why do we really lag behind, and what it takes to really implement something from innovation or evidence to make it like, to have an impact of it. So if we see the cycle of any innovation, it's like evidence or innovation which is like produced, and then we have the policy around it. But then I think at the local levels, there are like local discussions, local contextualizations, then financing issues. Then comes the systems part, like whether the system is really capacitated to deliver those interventions or those innovations. And then like, when it is really scaled and implemented, then only we see the impact. So why do we really have this divide? So, I mean, the answer lies in the steps. So there are like policy gaps. What we know, like, a lot of countries do not like, really adopt the WHO recommendations or the other global recommendations upfront, and there is a lag there. Then there are restrictive laws and regulations. There are financing gaps. Then, of course, the capacity of the health systems in terms of the workforce, the supply chain mechanisms, even the diagnostics, etc., really plays an important role. And then even if these interventions are taken up, there are equity gaps. We are not able to reach who really needs them. There are gender inequalities, geographic inequalities, and then, of course, they are topped by stigma and discrimination. So we just analyzed, and I'm just giving a few examples of the WHO guideline and where we really have lag in terms of having a policy and then like coming to the implementation to the full scale. And these are just like, some examples from HIV. So the viral load monitoring was actually like recommended in 2013. And by 2023, only 74 countries had adopted routine viral load testing for PLHIV. PrEP, it was recommended first in 2016. And by 2021, only 120 countries out of 180 countries had adopted in the guidelines. And when I'm saying adopted, there is a, large gap where like people really need to implement these. HIV self-testing, which was recommended in 2017, and still only 109 countries have policies, and 90 countries are implementing it. Differentiated models for service delivery and multi-month dispensation. Again, this was part of the guidelines in 2017. And I think COVID had a silver lining for this. So some of these interventions really got traction during the pandemic period, but post-pandemic, their scale and the quality is variable. Something which was really taken up very quickly was the DTG adoption. And DTG was like adopted by almost all countries very quickly as preferred ART regimen, and we saw a very rapid scale up. And this is something which really made a sharp change in the 95 cascades for most of the countries, and particularly the second 95 and third 95. So if the policies are adopted in a timely manner, they really have an impact. And the other piece is around the long-acting PrEP, which I think people were speaking about. So the initial guidelines were released in 2022, but still by 25, only 21 countries had adopted it. So we know like what happens and how much time it really takes. It takes like years from policy to adoption, and then full scale implementation is again a dream at times. One has to really understand that there is a cost for these inactions or delays, and whenever we are deferring any decision. So this may lead to human cost to the human lives, deaths, morbidity, mortality, the economic cost, and of course, I think our commitment to SDG targets is really compromised. What we know that has worked well, and we really listened to some good stories from community and from many of the countries, that's strong leadership, community-led responses, data-driven approaches, and integrated service deliveries really work well. We really need to change the things now. And we really need, from pilot projects, we need to scale up. From disease-specific silos, we really need to go into integrated approaches or convergent approaches. From short-term funding to more sustainable funding, and we had really good discussion about this. From top-down programs, we need to have community-led programs, and from measuring impacts to measuring the activities, we really need to move towards measuring the impact. And of course, equity is no-brainer. Equity is non-negotiable, and we really need to reach the people who really need care or the services. So just to conclude, what we really need to differently, and Dr. Polin actually left us with this thought, to just take it move forward. Basically, I think for any to bridge the divide between the policy and the implementation, I think we need to really keep innovating. So this is something which should keep evolving and really keep informing the program. But at the same time, we really need to accelerate and then sustain. And for this, perhaps what we need, I want to just leave the group with 4 Ds. One is the demonopolization of knowledge, information, and a lot of cross-learning is required for this, so that there is demand generation, people know what is available, and even in terms of the service delivery, people are able to really get it from community sides, from the peripheral sides. So the demonopolization of knowledge and information, and even the innovations, is really critical. Then we need to democratize the access, and this piece is very critical. If we really want to scale up, we really need to decentralize and go to the last mile. Then the third piece is around differentiation, and we need to differentiate for equity and reach the people, more of person-centered care. And again, perhaps we could think about the approaches where we could think of targeting some of the micro populations, subgroups, sub-national approaches. So those differentiation could really help us to fast track. And the other piece is the demystification for simplification as well as integration. So if we really want to go forward from here, and when we are talking about more convergent approaches, more simplification and community-led services, we really need to demystify all these innovations or all these policies so that the implementation is really easy. With this, I'll conclude. Thanks so much.
Yeah, thanks, Dr. Reshu. I mean, you are again reiterated the need to not only quickly scale up, but also take it to scale fast enough and bridge that gap between the policy and the implementation. Thanks for your presentation, Dr. Reshu. I'll move to the next speaker, which is Asmita Oja, who's a public health administrator at National AIDS and STI Program, Ministry of Health, Government of Nepal. Dr. Oja, please.
Am I audible?
Yeah, very well.
Thank you. Good afternoon, respected chair, distinguished speakers, delegates from around the world, colleagues, partners, and everyone. Thank you very much for the kind invitation. It is a privilege to join this important discussion and to learn from the experiences said by the colleagues from different countries. So I'm Asmita Oza, and I serve as Section Chief of in National Center for AIDS and STD Control of Ministry of Health and Safety, Government of Nepal. So it's an honor to represent Nepal and share our journey towards ending AIDS by 2030. So while I was thinking about this discussion, one question always stayed with me. If we already know what works, then why are some people still being left behind? Today, we have effective HIV prevention. We have life-saving antiretroviral treatment. We know that U is equals to U. We have effective TB prevention and treatment, and we have our clear global targets through 95-95-95 framework. So today, our greatest challenge is not evidence or science. Our greatest challenge is ensuring that this proven intervention reach every person who needs them with dignity, without stigma, and without barriers. So in Nepal, our HIV epidemic remains concentrated among the key population, and our response has been shaped accordingly, focused, evidence-based, and mostly community-centered. So over the last decade, Nepal has made encouraging progress. Our new HIV infections and AIDS-related deaths have both declined by about 76%, demonstrating our sustained investment in prevention, treatment, and community engagement that can save lives. On the prevention side, we have strengthened our targeted intervention for key population. We have expanded our HIV testing services, condom programming, harm reduction services, prevention of mother-to-child transmission, partner notification, and community outreach. On the treatment side, free retroviral therapy has been expanded across the country, bringing our services closer to the communities. More people now know their HIV status. More people are receiving treatment, and viral suppression continues to improve up to 97%. We are steadily progressing towards our 95-95 targets while recognizing that the last mile is our greatest challenge. One of the greatest strengths of Nepal's response has been our partnership with the communities. Networks of people living with HIV, key populations, organizations, civil societies, and development partners have been our central to our success. They help us reduce stigma, strengthen adherence, improve service uptake, and ensure that our response remains grounded in the realities of people that we serve. We have also strengthened the integration between the HIV and TB program, and because routine TB screening among people living with HIV, HIV testing among TB patients, TB preventive treatment and therapy, and coordinated case management are helping us to move towards a truly integrated and person-centered care. Nepal, alongside, is also working towards the triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B, integrating these services within the national maternal and child health programs. Another our important area of progress is the digital innovation. We have implemented our HIV care and ART tracking system, which is a client-based electronic system that follows individuals throughout the continuum of care and enables us for timely follow-up, supporting retention on treatment, reducing the loss to follow-up, and provide the real-time information for the program management and decision-making. Alongside, our national information system captures the overall treatment and prevention programs that are run through both the government and non-governmental organizations. Alongside, we are also strengthening our community-led monitoring, allowing communities and people living with HIV to provide the direct feedback on the quality and accessibility of services. So the technology helps us to identify the gaps while the communities help us to close them. As Nepal continues to make progress, we are also entering a new phase. Like many countries have previously expressed, we are also preparing for a gradual transition towards a greater domestic financing and national ownership of the HIV response. So this is an opportunity for us, not only an opportunity, but it also reminds us that the sustainability is not only about the financing, it is about protecting the gains we have made, ensuring our uninterrupted access to prevention and treatment services, and continuing to invest in communities, strategic information system, and innovation. So our main goal at the National Response Program is that no one is left behind during this transition. Despite our achievements, we know our work is not finished. Late diagnosis still remains a challenge. Stigma and discrimination continue to discourage people from accessing these services, and some individuals are still lost along the continuum of care. And still, TB remains a significant cause of illness among the people living with HIV. So these are not simply program gaps, these are the equity gaps. So as we move towards 2030, I believe there are three major priorities. First, we must continue putting our people, not programs, at the center of our response. Second, we must further strengthen our integration of HIV, TB, hepatitis, and other essential services so that the care becomes more simpler, more accessible, and more responsive to people's needs. And third, we must continue investing in communities as equal partners. Community leadership is not an optional component of HIV response. It is one of our greatest strengths. So let me end with one final reflection. As a public health professional, we often speak about targets and indicators, but behind every number is a person, a young person who needs protection, a mother who wants her child to be born free of HIV, a person living with HIV who deserves uninterrupted treatment and care without the fear of stigma or discrimination. If we keep those people at the center of every decision we make, I truly believe that ending AIDS by 2030 is not possible, it is achievable. So Nepal remains fully committed to working with communities, government, development partners, and all of you to make that vision a reality. Thank you very much.
Thank you, Asmita. Your message on people at the center of response is well received. Appreciate that. And also that government of Nepal is increasing their domestic support to the national programs. I'll move on to the next speaker, Dr. Imran Pambudi. Dr. Imran is former head of National TB Program at Ministry of Health, Indonesia. He's also former director of Communicable Diseases, Ministry of Health, Indonesia. He is currently director of the Vulnerable Group Health Services, again at Ministry of Indonesia. Over to you, Imran. You have a huge experience across various verticals, so over to you.
Yeah, thank you, Dr. Satyava.
Thank you.
Good morning,
Morning.
good afternoon, and also good evening for all of you. So, as mentioned by Dr. Satyava, that I will present now as a director of vulnerable groups. However, I will talk about how vulnerable groups is also impacted by the HIV and also tuberculosis. So, colleagues, friends, and partners, as we move closer to the 2030 Sustainable Development Goals, the next 54 months will be critical. We have made remarkable progress in preventing and treating HIV and tuberculosis. Yet, we are to achieve our global targets, and we must recognize one important truth, that ending AIDS and ending TB is not only about controlling infection, it's about putting people first. And when we speak of scaling community-led HIV and TB interventions, we are not only talking about a number or coverage. We are talking about impact, about making sure that every program reaches deeper into people's life, addresses their realities, and removes barriers that keep them from care. Firstly, safety is health. So community-led responses have already proven their worth. They bring trust, they bring innovation, and they bring accountability. But to make them truly transformative, we must broaden their lens. That means integrating violence prevention into HIV and TB programming, because no one can adhere to treatment or access services if they live in fear of violence. Secondly, ending ageism is part of ending AIDS. It also means confronting ageism. People living with HIV are now long-term survivors, and many are aging with resilience. Yet, too often, services are designed only for the young. We must ensure that older adults living with HIV and TB are not forgotten, whether in clinical protocols, social protection, or community support. Lastly, accessibility is a dignity. Equally, we must apply a disability lens. Accessibility is not optional. If our clinics, information systems, and outreach program exclude people with disabilities, then we are falling in our promise to put people first. Community-led initiative must champion inclusive design so that services are usable by all, regardless of physical or cognitive ability. Scaling impact also requires integration. HIV and TB programs cannot remain vertical silos. They must connect with mental health, reproductive health, and social protections. They must be embedded in schools, workplace, and digital platforms. And they must be financed sustainably, with government and partners investing in what communities have already shown to work. Finally, accountability is key. We cannot shift the goalposts. The 2030 targets are not negotiable. To reach them, we must bridge the deadly divide between what we know work and what we actually do. That means listening to communities, resourcing them adequately, and measuring success not only in infection averted, but also in dignity restored. Colleagues, scaling community-led HIV and TB intervention is not just expansion. It's about transformation. Let us commit to make them impactful so that every person, young or old, with or without disability, can live free from HIV, free from TB, and free from stigma. So let me reiterate 3 points to be highlighted. First, safety is health. Integrating violence prevention into HIV and TB program is not negotiable. Second, ending ageism means honoring people with HIV as a long-term survivors, not invisible patients. And the third, accessibility is a dignity. Every HIV and TB service must include a disability lens. If we truly put people first, we will not only end AIDS and TB, we will also build healthier communities where people can live longer, enjoy better mental well-being, age with dignity, and achieve their full potential. So let us rethink, rebuild, and rise together. Thank you. Back to you, Dr. Sadeva.
Thank you, Imran. You brought out important points. Your current lens talks about safety, person-centered care, disability, attention, accessibility issues, and also that now we know that people with HIV have survived many decades, and they are those who got infection many decades earlier are now old enough. I mean, they've reached an age where other comorbidities are arising, and we need to pay attention to them as well. So that point is very well received. Thank you, Imran, for your insightful talk. We'll move to the next speaker. Dr. Philip Matthew is had to leave so for some urgent engagement. I'll move to Sumit Mitra, who's a thought leader on bridging the deadly diagnostic divide in the global south. I had a privilege of working with Sumit. So over to you, Sumit. Sumit, are you there? Or Bobby, is Sumit online?
Yes, sir, he is online. Yeah.
Okay. Sumit, waiting for you to unmute.
Can you hear me, Dr. Sachdeva?
Yeah, very well.
Good evening, good morning, good afternoon, wherever you are. So yes, having been introduced as a thought leader, I think I have the liberty to kind of speak my mind, not being associated with anybody as of now. I want to kind of just say a few things. I started my career early in the 90s, 91, 92 to be specific. And I had started off by trying to market serology tests for tuberculosis. I ended my corporate life last December, also successfully trying to sell tuberculosis, namely the TrueNat. So over the course of these 35 years, I have seen Technologies come, technologies go, and technologies resurface. And also, the 35 years, my one takeaway for any disease elimination program was to fight a disease, you really need to find it first. And that's where the diagnostics comes. And I will stick to only that. All the other experts in the field have spoken. Just two simple thoughts that I latched on. First was from the Global Fund speaker, and then many of you have resonated that we today know what works. We today know what needs to be done. We today know what needs to be scaled up. In the TB diagnostics landscape, and I speak on behalf of Bharat, my country, which unfortunately is the gold medalist in the TB landscape, we today realize that a point of care molecular solution like the TrueNat absolutely works. And I'm very, very happy to say that the government of our country have spent a lot of resources, primarily from its own funding, in ramping up. Today, there are about 10,000 odd TrueNat devices across the country, but that said, that is only probably less than half of what we need. I'm sure the government is aware and they will take further actions. My first question as a thought leader is subsequent to what happened in India. 5 years back or 4 years back, whichever be the case, Global Fund started the introduction of the New Tools Project. 4 years, 9 to 12 countries, the highest TB burden countries. Are we supposed to have an answer whether the INTP project was a success with the TrueNat, where it was rolled out? If yes, what has been the scale up of the TrueNat in those countries? And the second question that I raise is again a fallout of what we have gone and seen in the very recent past of new technologies, and I have nothing against new technologies coming in, of newer technologies that kind of works for only 30%. If I were to take the paper published by FINE WHO on swabs, that technologies that work on swabs have been granted 5 or 3 million tests, 5,000 devices, even before it has kind of reached any kind of commercial activity. So essentially what I'm asking is, if the kind of rollout that you're seeing for the other systems are in that scale, what about the balance 60 to 65%, 70% of people where sputum is the major sample type? What kind of scale up should we be talking about? Tough questions, I know, easier asked than implemented. I'm sure there are issues of finances, issues of stuff like that in a tough times in the world that we live in. But at the end of the day, if we are saying that we really know what works and the idea is to scale, then aren't we doing just the opposite? I heard our team from Lakshadweep mention how they became the first TB-free kind of landscape in the Indian context. I would request folks across the globe to really go to Lakshadweep and ask them, speak with the team to figure out how they did what they did and how simply they did it. Before leaving, I just wish to say this. Everything works within systems, within the constraints of the severe financial constraints that we are in, et cetera, et cetera. But at the end of the day, ask yourself the question, am I doing what I say that I'm going to be doing? Or at the end of the day, do I make a trade-off? I pause here. I hope these questions are thought-provoking. Thanks, Dr. Sachdeva. Good to see you after a long time.
Thanks, Sumit. True to your what we said, you are a thought leader. You have left us with points to ponder. I mean, how do we introduce new technologies? How do we take them to scale? Do we need to have a differential approach to sort of adoption, etc.? Many points to brood over. We will do that. But I'll move to the next speaker, Dr. Ishwar Gilada, who's I already see him on the screen. So Dr. Gilada is a renowned HIV/AIDS practitioners of dermatology, STIs. He's also a governing council member of International AIDS Society and AIDS 2026 program committee member. We all know him as a dear friend. Over to you, Dr. Gilada.
Thank you very much, Dr. Sachdeva.
Yeah.
With nearly 40 years of experience at the intersection of HIV and TB, I still call myself student. I do not know how much expert I am. The tragedy is not the lack of knowledge, or we know how to prevent, how to diagnose, how to treat, even how to eliminate, but still the burden is rising. Yet TB remains the leading infectious killer. This thought, which has been said, that what we know and what we do, reminds me of Dr. Jonathan Mann, one of the tallest leaders in the field of HIV. People of my age and my experience in this field would know him. He used to say where we are and where we need to be. And that really is a paradox. And this paradox is like, this is a rainy season in Mumbai, a monsoon in Mumbai. It is like potholes in Mumbai. And for 45 years, I live in Mumbai. I know that there are potholes. We know how to overcome those potholes, but still they are there. And the same thing is there in the field of HIV and TB. HIV and TB together itself is a paradox. HIV is 100% preventable, 0% curable. TB is totally opposite. It is 0% preventable, 100% curable. But still they come from South and North Pole to Equator and they coexist. Now, we just heard a speaker from South Africa. South Africa is 5% of India's population. But in PrEP, they are 20 times ahead of India, in numbers also, not percentage. So when we talk about India being the leader in making pharma and reaching out to all over the world, but still we do not have proper PrEP. Now, if we look at what we know that HIV and TB must be tackled together, but still there are two different departments, and at every hospital, every place, they are tackled differently in different OPDs and by different people. Early HIV diagnosis and immediate ART reduces TB, but we hardly do that in real sense. We do not offer even PrEP. We do not offer even TB lab test, because in HIV, if TB lab test is done, which is maybe costing peanut, but it is available only in program. It is not available in private. We have a rapid diagnostic which exist. We have effective HIV TB medicine which are available. We have community-led services, and the example is Sahibi project in Mumbai and elsewhere where it was replicated. And we know that those programs are successful. We know that stigma is a major barrier, but we took 3 decades to have HIV/AIDS Act 2017. Now, when we look at implementation, I will go from the last. The 3 decades are passed for making the law, and in last 1 decade, not a single case is registered in the country under this act. So that means this act is just on paper. It is not even implemented. So when we look at what we need to do, we need to do a lot in different fields, and we have a fragmented system, and we often work in silos. We have delayed diagnosis, and there are still people come at very late stage in HIV. Inequity and social extinction. So if we talk about the marginalized population, currently we see the HIV rates are highest in that kind of population, where that should have been a priority to work there. So whether they are injection drug users, whether they are sex workers, whether they are UDX community, whether they are LGBTQ community, whether they are jail inmates, there we are not even concentrating our work there. Stigma I already spoke about, and discrimination exists. But without this act properly implemented, it will continue to exist. The political complacency is there. So in political complacency, PrEP, all over the world, India is providing PrEP. but in India it is not in policy. So there is a policy paralysis, and that is also policy paradox. We have insufficient accountability. Now, when we look at what needs to be done, and we need to put people first. So this is a people-centric approach has been also introduced by the International AIDS Society. Put people first. We have to integrate HIV and TB services everywhere. So there should be one-stop shop everywhere for HIV and TB together. Scale up the prevention with urgency. We should have used data for action, not just for reporting. And there are many places where we see data, but there's no action on that. We have to invest in frontline healthcare workers. We have to train, support, protect, and value them. And we need to partner with communities as equal leaders, not at the end of the ladder. And we need to also look at ensure sustainability, financing, and accountability. So basically, ending AIDS and ending TB by 2030 is not a scientific challenge. I call it an implementation challenge, an equity challenge, and above all, a leadership challenge. Thank you very much.
Thank you, Dr. Gilada. I mean, you're such an eloquent speaker. We all know that. And you raised important points. But I also know that you have been activist, advocate, and have been instrumental in rolling out and getting to see many new interventions, including the HIV/AIDS Act. And I think the next phase will need more people like you to support those endeavors.
Only one more point before I go away.
Yeah, sure.
India is the only capable country globally which can do this, ending HIV and ending tuberculosis. Now, all over the world, researches are done, but making it available, affordable, reachable to people in quantum which is required, only India can do that. And therefore, we should exploit that situation of India and do that in world.
Yeah, we all need to push decision makers, policy makers from a paralysis stage to an action stage. So let's move to the next person who may take some action on ground, which is Dr. R.K. Sood, who is District TB Officer and District Health Officer at the Government of Himachal Pradesh. He has done a tremendous work in TB care and control. Over to you, Dr. Sood.
Thank you, sir. Thank you, CNS team, for having me at this event. Really learned a lot from all the eminent speakers, and I endorse their views. Speaking last, my job remains to summarize. But looking at the positive side, India has a lot of success stories. The Indian HIV program has leveraged Mission AIDS Suraksha, which is 95, 95, 99 targets. And we are leveraging this tracking of all the vulnerable populations, timely testing, tracking every individual for continuum of care, and trying to ensure this viral load suppression. So lot of things are going on, but definitely lot of gaps remain, just like Dr. Gilada shared that HIV/AIDS Act implementation is a big gap. Similarly, the TB Mukt Bharat Abhiyan is, I think, the biggest TB care at scale, the biggest screening campaign, and I think upfront NAT, digital handheld technology, AI supported screening, differentiated care, TPT, and unprecedented community mobilization. And one of the innovations that Indian program has done is integration with the NCD, because the finances are in the NCD. So the Ayushman, the Nikshay Shivir was renamed as Ayushman Arogya Shivir, and so we have funds for those Shivers. Similarly, domestic financing has increased in India a lot. So that has been one of those good things. And our experience from Kangra shows that it's not just the technologies alone. It is the people behind the technologies, the enthusiastic teams, the decentralized decision making, the real-time use of data, community ownership, and enthusiastic teams which help us achieve all these things. But now the challenge that we are facing right now is, with 3 years continuous of the TB Mukt Bharat Abhiyan, sustaining the momentum has become a challenge. Earlier in our shivers, we used to get 500, 600 people a day. Now getting 200 people a day is difficult. So that burnout is showing on the ground. So how we try to sustain the momentum, and our way to put people first, save lives is, and keep our team motivated. That is the real, I think, way we need to move forward. Definitely, a lot of good questions have been posed by a lot of people. Lot of things also need to be done at the policy level, and meanwhile, with the existing policy, whatever we can push through. So that is the, I think, current leverage that we have. And because India has very good domestic funding of the TB and HIV response, so we are relatively well placed to push this forward. And like other speakers also said, that India is the hub of innovation, India is the hub of a lot of things in pharmacy. So we can definitely adopt the new tools and technologies like PrEP, and that need a bigger call at the higher levels. But at the ground level, pushing the existing provisions, I think that is one of the good things. And I think motivating our teams and putting them what you call into a overdrive, that is how we are trying to move it. Thank you, sir.
No, thank you, Dr. Sood. You brought some certain optimistic points of implementation and others, but also raised an important issue of human resources, burnout, and motivation. We note that, and yes, we must find a solution to how do we keep our workforce motivated. But having said that, I'll hand it over to Shobha Shukla. Thanks for having me, Shobha, and over to you.
Thank you, Dr. Sachdeva. Thank you for really conducting the session so well. And now I would request Dr. Raman Ganga Khetkar to please deliver the closing remarks. Dr. Ganga Khetkar is former head, Division of Epidemiology and Communicable Diseases, Indian Council of Medical Research, and is currently a distinguished professor at Symbiosis International University, Pune. Welcome, sir.
Thank you, Shobha. Am I audible?
Yes, very clear, sir. And thank you for staying with us for so long. Yes, you are audible. Hello. Yes.
Okay. Thank you. Now, I know we are perhaps a little late in concluding these sessions, and I have a onerous task of trying to summarize and say what could be way forward. Just a few thoughts. I won't take longer time. No, we have to remember that we were progressing well, whether it is HIV or TB, well until COVID pandemic struck us. It reduced our own funds that could have come to it, mainly because COVID required huge amount of funds towards its own prevention and control activities as such. What is also important for us to remember that it led to health being prioritized at a lower level, and that has been further accentuated by the geopolitical tensions that we are currently passing through, and financing health is becoming an issue which is very much evident everywhere. Now, we heard a lot of presentations. Some of the presentations which I can quote from the community which were important was Dr. Sita. She brought out an access related issue, which is part of universal health USC. No, that is something which is important for us to remember. Second thing, you looked at TAL. TAL is a comprehensive community-led service delivery model, which is perhaps also important to reflect upon. You heard Bela, who talked about their approaches towards how to test those who are vulnerable, who are less than 18 years old, and they had their own innovations which require a lot of advocacy if we have to do it everywhere. But we must also remember injection drug use. was not a legally acceptable. It is legally tolerated issue which is currently being handled by HIV programming. So we don't know how we will handle this issue and whether we would be successful. To me, it can be a successful approach if we try to advocate for the same. And then we heard Happy, the person from Happy who talked about HIV, their work with the HIV infected individuals. And what they found was really well, that those who were infected, they tended to adhere very well towards TB treatment per se, which essentially brings us to one thing, that those who are health conscious perhaps are likely to adhere well, and they are a critical element for the success of any intervention that we would like to try. Now, if we look at this particular issue, we also need to look at how do we do programming across. When you reflect, we reflect most often now in high burden stage, whether it was for HIV, whether it was for TB. And then eventually, as the program matures, we tend to forget or give less priority to primary prevention. What we need to remember is we tend to intensify focus on those who are infected and vulnerable population. Do such compartments actually help us? Do we think that if we continue such an approach, even when it would come towards the disease elimination targets, to me, perhaps, one of the issues that perhaps needs reflection is it is likely that keeping those away from primary healthcare programming perhaps will sustain stigma, and we will never be able to involve the community or mobilize the community in a strong possible way. If we balance primary and secondary prevention well, I think we will do well. And what we need to do in order to do that is involve all the population, even if they may not be infected. We can't forget primary prevention, and that balance has to be maintained really well. Now, what is also important for us to think about is, there are certain strategies which we haven't tried in the community. There used to be one model called as Community Opinion Leaders Model, which was also called as CPOL, where a community leader is sensitized and then he tries to ensure that the messages reach the population and people tend to accept their messages as such. So if we want to mobilize community, can we use CPOL-like approaches? That's something which we should look at. Can we not use peer-led symptom screening, at least, in order to see that those who perhaps appear to have symptoms, which could perhaps be good for screening, can they be sent for testing ahead to a healthcare facility? Is something which we should reflect on, because this is not going to add to your cost. That becomes pretty easy to handle if we mobilize community in the right manner. When we think in terms of integration, what is it that we generally see? When we talk of integration, we try to integrate when the incidence goes down. And if we look at it at both the diseases, perhaps we are not at that particular stage. But is that the right model to look at for integration? Perhaps we need to evolve good models where you involve the community right in the beginning of such a program and sustain their financing and their role very strongly, even when the program tends to mature and is coming towards elimination. What is also important for us to remember that elimination will require a strong community mobilization. Otherwise, you will find that we may end up in having the same infections coming back again and again. What we need eventually, to summarize, evidence-based dynamic policy making. We need to use the modern technologies, including AI tools that would be available to us. We need to bring in accountability through community mobility, community mobilization, and community monitoring. We need to bring in transparency so that people can react and perhaps help improving the local situation. And we need to have a decentralized planning for all such services to be provided, because one size will never fit all, and we need to have strategic reflections occurring at even the smallest of the units where we are going to operate. Community should also reflect on whether the level of advocacy that they need is happening in the right way. Do they need to have different communication strategies is something which they should reflect on. You need to involve civil society. Its involvement actually has to increase as we go towards elimination rather than decreasing at that particular point in time, because the task or achievements become more and more difficult as you go towards elimination. We need to involve younger population for giving sustained health messages in the community and ensuring that the community stays together and keeps on understanding the different disease dynamics that tend to exist. And we also need to ensure that these messages that we would like to provide from the younger population or younger age groups, they should not be only towards HIV, only towards TB. Perhaps, they need to have all health-related problems at an appropriate messages can be given to them through that, because universal health coverage would essentially require community. And if that has to happen, you need to have people who understand what is their own responsibility. They should be aware of all the symptoms that can occur, the major complications that can occur after an infection, and how easy is it to prevent. What is also important for all of us to recognize is the difference and try to ensure that health as a basic human right is accorded to people over a period of time. I'm sure together we will still work towards disease elimination targets strongly and ensure that every country will perhaps move in a manner that will be in consonance with what is expected from the programmatic goals. Thank you.
Thank you very much, Dr. Ganga Khetkar, for your insightful remarks, particularly about the need to focus more on primary prevention and also involving the community right from the beginning of designing programs and policies. With this, we come to the close of this AIDS 2026 affiliated independent event. On behalf of all our partners, I thank the speakers as well as the audience for their active participation as well as for their patience. Let us hope that the learnings from this event will help in enhancing our efforts to scale up person-centered, rights-based, and community-led solutions and keep the promise of the 2030 targets of ending AIDS and TB both. Namaste and have a good day.
Thank you.
Thank you. Bye-bye.
Bye.